Good morning, everyone, and welcome to day 2 of the fourth Radiology Breast Cancer Symposium. I'm Dr. Walal Zubair, your moderator for today, joined by co-moderators Isra, Haifa, and Hiba. We are excited to continue advancing breast imaging and women health. A quick recap. Yesterday, we covered topics like inflammatory breast cancer disease and digital tomosynthesis. There were amazing sessions. Today, we are diving into automated ultrasound, AI, and more with 15 expert-led talks. Please mute your mics when not speaking. Use the chat for questions and keep to Khartoum time. Let us start with our first session at 9 a.m. Welcome. So our kick of the day too is with Dr. Hiba Mohammed Osman. Dr. Osman is an associated professor at University of Calgary and staff radiologist at EFW Food Health, South Health Campus, and Richmond Road Hospitals in Calgary, Canada. She holds fellowships in breast and cross-sectional imaging from McMaster University, body imaging from Ottawa University, and emergency radiology from Ottawa University. She was also a former executive committee member of the Sudan Doctors Union, Canada from 2020 to 2024. Her topic is automated breast ultrasound. Dr. Osman, you have 30 minutes. Over to you. You can share your screen now. You are muted, Dr. Osman.
Sorry. So do you see my screen now?
Yes, perfect.
Yeah, good morning, everybody, and thank you for having me today. Thank you for the organizing committee for the hard work. And I'm going to talk about the automated breast ultrasound and the additional value in screening of the breast cancer. Automated breast ultrasound is combined with the mammogram, increase the cancer detection rate by 2.7 to 4.6 cancers per 1,000 women screened. Screening tool for women with dense breast parenchyma, density C and D, and it is the acquisition time is significantly lower than handheld ultrasound. The images are available for the radiologist for interpretation on a later time, unlike the handheld ultrasound where the radiologist should be available and review the images at the same time. This improved the it also improved the reproducibility and identifies mammographically occult and small breast cancer missed by mammography. And we all know that there is 15% of breast cancer that are mammographically occult. This is the images that acquired with the automated breast ultrasound. So the automated breast ultrasound will acquire the images in 3 planes: coronal and axial and sagittal views. This is the coronal, and in this coronal images, we can easily identify if there is black holes or any lesions in the breast parenchyma. Next is the axial images, and in the axial images, if you look at the cursor here, the probe will go from down to up, and then screening the whole breast parenchyma. in the axial images that we are used to look in the usual sweeps during the handheld ultrasound. And this is the sagittal image where the cursor is going from the right side to the left side, and it will acquire the images. So this is the workstation that we report from. So the images will be displayed in the coronal image, and it displayed in the axial images as well. So in the coronal image, the blue circle is the annotated nipple, and we acquired the images in 3 batches. This is the routine protocol is 3 images, taking the lateral breast and then the mid breast and then the medial breast. With patient with bigger breast, sometimes we need to take more images, and if there is more tissue in the superior aspect of the breast, we take more images for that. So down it will be annotated that like right AP, right lateral, right medial, and for the left as well. In the program, you can just navigate with the arrows to see the right breast first and then the left breast. Those are like the different layout. You can look at only sagittal or only coronal. You can look at coronal and axial together. You can look in 3 together, like whatever you prefer. This is the measurement tool, and this is the magnification glass that can increase the will zoom the image for you,
خيارات هنا.
show you the images better. You can also save images from key images from the presentation and send it to the PACS for reporting. This is a study about the sensitivity of the automated breast ultrasound versus the handheld ultrasound in detection of breast cancer, done by Polka et al. And he demonstrated that the automated breast ultrasound alone has a sensitivity of 95.3%, while the handheld has the sensitivity of 90.6, and this is giving the operator dependent in case of the handheld ultrasound. Although the specificity of the handheld ultrasound is more than the automated ultrasound, that is because like with the handheld ultrasound, you can look for the margin very, very carefully, and you can put power Doppler, you can use the other characteristic, you can identify the areas of shadowing or areas of posterior acoustic enhancement better than the automated breast ultrasound. In the same study, they studied the sensitivity and accuracy of the automated breast ultrasound plus the tomosynthesis and compared to the MRI. And that showed that the sensitivity of the automated breast ultrasound plus tomosynthesis is 76.5%, while the MRI is 91.7%. Though the diagnostic accuracy is comparable, giving the automated breast ultrasound and tomosynthesis of 90% versus the MRI is 93.8%. This is a quick video from one of our clinics here, and it it shows the machine itself. So when the patient comes to the clinic, the most important thing is positioning the patient. Sorry. And then this is the probe, and the probe has different pressure. So that's how we acquired the images. Um, so now I will come to the first case. This is a 67 years old female came for screening. So on the mammogram, honestly, we didn't see much. We see only area of focal asymmetry in the lower inner quadrant, middle third of the right breast. The left breast, we didn't see anything on the mammogram. This is the automated breast ultrasound, and there is irregular shape hypoechoic mass in the lateral aspect of the right breast. So we usually acquire the mammogram and the automated breast ultrasound together, uh, unsupervised. Then the radiologist will report them together, and we will call the patient back for additional views. In the additional views, we did compression view. There is focal asymmetry in the lower inner quadrant, and we didn't see anything else on this one. So on the automated breast, and then we usually take the we save this to the PACS, and the tech will check the clock and the distance from the nipple to have to guide her during their handheld ultrasound. So this is the handheld ultrasound, and at 10 o'clock position, 8 centimeter from the nipple, very lateral in the axillary tail. We see this irregular shape, hypoechoic mass with ill-defined margin. There is some posterior acoustic shadowing. We biopsied that, and this came back as invasive ductal carcinoma associated with ductal carcinoma in situ. We placed a magnetic seed for localization for the surgeon, and this is the lesion very far there in the axilla, and hardly we can see a tip of the magnetic seed in the lateral aspect of the breast. This is the specimen radiograph, and this is the magnetic seed. This is the speculated hyperdense lesion in keeping with invasive ductal carcinoma. Second patient, this is a young patient came for screening, and anybody see anything on the mammogram? You can also share your response in the chat box. So the only finding we saw here is asymmetry. And because it does not show that much in the CC view, we call it asymmetry in the upper half of the right breast. Otherwise, we didn't see any abnormality on the mammogram. On the automated breast ultrasound, and here, when you select your target, the machine will calculate for you the clock, the distance from the nipple, and the distance from the skin. And here it is at 12 o'clock, 6.5 centimeters from the nipple. And the machine easily calculate the distance from the nipple, because the tech, during acquisition of the images, will mark the nipple. So the distance from the nipple is 6.5, and this is very important to guide the handheld ultrasound. This is the saved images from the automated breast ultrasound, and again, it does show that the lesion is irregular. Usually, we don't go in depth in characterizing the lesions, because this is mainly a screening tool, and we always use the handheld ultrasound for more characterizations of the lesions seen on the automated breast ultrasound. This is the handheld ultrasound, and it demonstrates like a irregular shape hypoechoic mass at 11 o'clock position. Like the distance from the nipple sometimes varies, and because during the automated breast ultrasound, the breast is stretched more than the handheld ultrasound. So and also because this is operator dependent, and then the there is some variation between the depth between tech to other. So this came as a B-cell lymphoma, biopsy proven, and it demonstrate like intermediate uptake in the PET scan in the upper half of the right breast. And this is the follow-up after one year of treatment. The breast lesion is smaller in size, and this is the beauty of the automated breast ultrasound, that you can easily compare the previous studies, and even if you have lesions that showed is not fully characterized, you can go to the ABIS that you have 2 years ago and look in the same position, same distance from the nipple, and you might see the lesion. If the lesion looks similar, measures similar in 2 years in interval, that is by definition BIRATSU benign lesion, and that can help us to reduce the recall rate. This is our NG suite, and we had our first cryoablation earlier this month. Okay, second patient. This is a mammogram um, density C. So anybody sees anything on this mammogram?
Distortion in the right side, in the left,
In the left, where about?
central, retroareolar, central posterior,
In the
12
CC?
o'clock.
It's 12 o'clock.
Yeah,
Sorry, it's rabbit here.
yeah, upper outer. And
And
calc,
do you see it in the MLO view?
both views, upper outer. So
Outer.
I
And
can
which,
hover.
yeah, what is the depth?
Depths, it's just in the anterior retrofatty area. That one?
I guess you're
This one?
talking about this one.
Yeah,
And where about in the CC? Around
thi-
near
this
the
one.
calcification?
Yeah,
Okay,
It
let
is
us
not
see.
upper central, not
Upper
upper
center
central,
here,
more anterior.
more
Yes,
anterior here.
yeah, subtle distortion is seen here.
Yeah,
I'm not
so
sure. Mm.
it does not, like if you're talking about this area here,
Tiny area, tiny area.
yeah,
Here, behind the nipple on the CC view,
and
there is
on the
subtle
CC here,
distortion.
yeah. Okay, let us see. So on the automated breast ultrasound, we see a small lesion at 130 clock position. So it correct, yes, it's in the upper outer. It just more close to the nipple. The distance from the
Yeah,
nipple here in the automated breast ultrasound is says for 5.5, but in the diagram it does look like it is in the anterior third. This is another coronal view for the same lesion. And this is the lesion on the handheld ultrasound. So it is a regular shape lesion with um, there is no posterior acoustic features, and by this is the biopsy, and it's very important to show that the biopsy needle is going through the lesion in two planes, and that will help to determine if the biopsy was concordant and the sample was adequate or not during issuing the pathology radiology addendum report. And this came back as invasive ductal carcinoma. Okay, so next patient. Any clue?
Right breast, more denser.
Uh-huh.
There are benign calcifications scattered in the upper breast
Mm-hmm.
and asymmetric density in the medial aspect of the right breast in the
Mm-hmm.
CC.
Yeah.
Otherwise, I can't see anything else.
Yeah. Well done. Those kind of breasts are really nightmare during the screening. Like with now we're doing all of our cases tomosynthesis. That helps us a little bit to detect lesions, but it's still the extremely dense breasts are very difficult and challenging. So correct, yes, this is the lesion seen in the medial breast of the right in the right side, and it is situated at 230 clock position, 5 centimeters from the nipple.
There was indirect sign in this case, the increased vascularity, asymmetric increased vascularity in the central to medial breast on the right side, along with increased density. That can raise that something wrong on the right breast.
Mm-hmm.
Can you see the vessel, the big vessel on
Where?
mammography?
Yes,
Yeah,
agree.
this is indirect sign that alarming for underlying pathology.
Mm-hmm. And this is more images for the same area in the coronal and axial image here. So like the difference in the location here, this is the medial view. So it's centered like in the medial aspect of the breast, where this is the AP view, and the lesion is centered in at the edge of the film. And this is the annotation will show you exactly where is the lesion is. And this is very helpful for the technician to know where to scan during the handheld ultrasound. So this is the handheld ultrasound for the same patient, and there is irregular shape hypoechoic mass with cystic changes. There is surrounding vascularity. And ultrasound guided biopsy confirmed fibroadenoma with fibrocystic changes with ductal ectasia, no evidence of malignancy. Now, when we show the report, the pathology report, usually we state our recommendation. So if you see a lesion that is indeterminate, really, it has a little bit irregular margin, fibroadenoma is concordant, but you're still a little bit worried, you can just recommend a 6-month follow-up ultrasound for that lesion.
Yeah, if it is fibroadenoma, it means that it is a complex one because it is associated with fibrocystic changes. It is not just a simple typical fibroadenoma. And a simple, I think, a complex fibroadenoma can be upgraded if you, I don't know about your protocol, but
Yeah,
complex
in our
fibroadenoma, it is at least 5-4A, and sometimes they recommend to be excised for excisional biopsy in some centers.
yeah, in our centers, they try to not excise fibroadenomas. So if we are worried, we just follow them in 6 months, and if it does increase inside, then we can recommend surgical consult for excision. Also, like previously, they were resecting every papillomas. Now the new protocol, like with the increased number of increase the detection level and increase the number of benign lesion. If it is small lesion and then there is no worrisome features, they tend to observe them. So like they're changing the protocol a little bit to suit the current situation in our institute. Next patient is 42 years old. The patient came for screening. Any clue?
Also
For me,
right side.
with the viral infections, my concentration is very low.
Area of architectural distortion in the right lateral posterior.
Mm-hmm.
The nipple on the left side seems to be retracted or positional.
On the left side?
The nipple, I'm asking, is it positional or retracted?
It is positional.
Mm.
I agree with Sarah. Right lateral, posterior.
So anything on the left side?
Posterior central.
Medial in the there is added density. I'm not sure if it's artifact or lateral. There is distortion in the contour,
There is
anterior
calcification.
Not calcification, no.
Contour of the anterior fat glandular interface. Subtle distortion is there. I'm not sure if it is.
There is increased density in the lateral breast in the left also, Dr. Rabab. Yeah?
Yeah, posteriorly, yes.
Yeah.
So the main
Very
abnormality,
asymmetry.
which quadrant?
Upper
Outer.
upper posterior here, with
Outer.
even tethering of the pectoralis muscles and lack of fat interface.
Yeah, it is very challenging cases. Actually, like we reported this mammogram as normal. We didn't see anything on the tomosynthesis as well. So on the automated breast ultrasound, we saw a small lesion at 4 o'clock position here. And then this is this is the axial image of the automated breast ultrasound. So it is hypoechoic lesion. We brought the patient for handheld ultrasound, and it demonstrates irregular shape hypoechoic mass at 4 o'clock position, 4 centimeters from the nipple. And the biopsy came back as intraductal papilloma. And here to show you the post-biopsy clip, we don't see, honestly, we don't see anything at all on the mammogram in that particular area. I do agree with you, this area was suspicious on the previous, but on it has been stable for in the previous mammograms, and we didn't pick this area on the mammograms only. So this is intraductal papilloma.
Can you go back for the first mammogram? Bilateral mammogram.
No way, Dr. Hiba, no way we can dig
Oh,
on
yeah,
this
yeah.
case.
I know
honestly.
that. Yeah, I'm just showing you the beauty of the
This is very
yeah,
beautiful. Yeah.
but
actually there is only that.
Amazing,
yeah,
amazing work.
The strange one is that asymmetry associated with distortion of the pectoralis to be normal parenchyma.
Yeah, because just we pass it because it has been stable in the previous mammogram, many years ago.
Might be related to minor trauma or something causing that tethering.
And also in the automated breast ultrasound, we didn't see anything in the upper half of the left breast.
The more challenging thing in this case, I think the breasts are not symmetrical. Even
Yes. exactly.
So it is very difficult to
Yeah.
clue
They-
where is the abnormality.
Yeah. So that's why I feel that automated breast ultrasound make our life
Helpful.
much easier,
Yeah.
Yeah,
because
it
if
is really
you
helpful.
don't
It is
see
helpful.
anything on
Very
the
helpful.
mammogram, you just go to the ultrasound and you have the
On
whole breast
retrospect,
for you, and then you can just correlate if there is,
now
because
on
if
retrospect
this
only
size you
should be appreciated. On retrospect, below that asymmetry, yes,
yeah.
the small area below the asymmetry. On
Yeah, but just
retrospect, now
you
we
can't
can see it. Like
yeah,
before,
but you
we
can't
did
call it
not
out.
observe it.
Yeah,
Yeah,
and there is some areas like patchy area of asymmetry in the other breast as well, so you can't call this like
yeah.
it's,
On
yeah, for me
retrospect,
it's like possible to call area like this on this mammogram. Okay, next patient. uh, so this is a screening mammogram, CC and MLO. I don't know how many minutes I have left.
5 minutes if you have
How
more.
Okay, I have many cases, so I'll go
Okay.
like, so this also we didn't see anything on the mammogram, and then
even in the left breast,
on the left breast. So the
like
abnormality is
posterior.
in the left breast here, this area.
Uh-huh.
Could be it is there is like increased density in the
Something
nodal
there is,
zone.
yeah,
Yeah,
the
yeah,
asymmetry. We can
sure.
call it as asymmetry only
Yeah, sure.
with subtle distortion.
Mm-hmm.
Yeah, I can see
So
no calcification,
no
or
calcification
I'm imagining.
here. No calcification now.
Okay, okay.
Okay.
But this
So
area, I will just raise it. I'm not sure.
yeah, the good thing that we like most of the patient they start their screening at the age of 40, so in most cases we have previous images for comparison, and that will solve like areas like this for us, and
Mm.
also like the automated ultrasound can help. So we in the automated ultrasound we saw this lesion uh, at 5 o'clock position. So, and it's not far from the nipple. It's only 3 centimeters from the nipple. And this came back as benign breast tissue with stromal fibrosis.
Concordant.
Concordant, yeah.
Mm.
And then this patient, the next patient, most of my patient, we didn't see anything like anything on the mammogram. Like there is area of focal asymmetry in the upper outer quadrant of the right breast. And then on
What about the left breast?
yeah, this was
Posterior, lat,
yeah,
posterior.
this was temperature distortion in the
Mm.
left breast. And on the MLO, like, yeah, it's really subtle, you can't see it very well. And then this is the tomosynthesis image that showed the architecture distortion and the speculation better. And this is the cone compression view. Still, there is architecture distortion. And on the automated breast ultrasound is very impressive. It is like, remember I told you to look for the black holes. So this is like in the coronal, we see hypoechoic area, and there is shadowing. Even we can see it in the automated breast ultrasound. And on the uh, ultrasound, it is very suspicious lesion, irregular shape with posterior shadowing. It is invasive carcinoma with lobular type, grade 2. This is the post localization, and the clip is seen in the medial breast. I'll just go very quick in the same area of architecture distortion. Next patient, this came for also for screening. The on the mammogram there is not much there, and probably like I found also the automated breast ultrasound. Like when I found the lesion in the automated breast ultrasound, I go back to the mammogram, I can't see it, and that will by time that will increase the detection level and make your eyes more trained to detect subtle lesions. So the lesion is in the upper quadrant of the left breast, and it is suspicious lesion. This is invasive ductal carcinoma. This is the localization with the magnetic seed, and it is in the upper outer quadrant of the left breast. Yeah, this is our prayer area in the ultrachild, and luckily they make wudu area for us. This is the check check sheet for the patient, and we usually ask them if they presented with anything. This last patient is presented with a breast lump. She came for screening, but when the technician asked her, she said she has breast lump. And we asked also about the pregnancy, hysterectomy, tamoxifen, and hormonal replacement, any procedures to the breast, and any family history. And the patient usually draw for us if there is a where is the palpable lump, if there is any skin mole, any skin changes, they would draw it in this diagram. So this patient is extremely dense breast parenchyma, and the BB marker, yeah, this is the palpable area, exactly, and it's really hard to see it on this mammogram. And this is the palpable area. Like on the MLO, I see there is a asymmetry in the upper half. And like in the tomosynthesis, like you kind of see some masses, but the surprise is on the ultrasound. So when the patient came for screening, she presented with a palpable. We changed the whole procedure. We changed it from screening to diagnostic, and the automated breast ultrasound to handheld, because we need to look for the specific area of concern, and we need to characterize the lesions. So at 12 o'clock of the left breast, we found a couple of lesions. Those are different lesions, and then we got this big lesion at 10 o'clock, position 5 centimeter from the nipple. And like there are at least 5 lesions seen on ultrasounds. We biopsied 2 lesions to confirm the multifocal disease, and both of them came as invasive ductal carcinoma, and those are the post-biopsy clip. And you hardly see anything, like it does not correlate the big size of the mass with the area seen on the mammogram. And this is
tomosynthesis doesn't work in extremely dense breast, yeah?
It helps, but not that much. Like in
Yeah, it's better
extremely dense.
in heterogeneously, yeah, it is.
Yeah,
It's helpful in
exactly.
heterogeneously dense, but in
Yeah,
extremely dense, its
yeah, I agree.
sensitivity a bit lower.
Yeah, I agree with you. So this is her mammogram, and look at how much the disease is. There's at least 8 masses in the upper inner quadrant of the left breast. This is at the level of the nipple. There is some. This is a little bit higher, and this is the 3D CAD image, and demonstrate multiple suspicious lesions with heterogeneous enhancement and areas of washout. And thank you very much.
Amazing lecture.
Thank you very much, Dr. Hiba. That was very insightful. Thank you very much. Let me share the next.
We enjoy it, really we enjoy it.
يعني شوفي القسوه يا ولد، شوفي الحلاوه. طب الدكتوره بتاعت طبيبه الاسنان حنينه، بتحس بالم المريض بتاعها، فقالت ايه؟ بدل ما اعذبه ابنجه وبعدين اشيل اسنانه عشان يحرم بعد كده يلعب بايديه. تروح جايه الاستاذه المشتركه في.
So thank you again, Dr. Hiba, for this insightful start. Next, we have Dr. Tasabih Al-Sayed Muhammad, radiology specialist with an Arab board certification, specializing at Gulf Radiology and Laboratory Diagnostic Center. Her topic is breast implants and reconstruction, imaging and complications. Dr. Mohammed, please go ahead and share your screen. Hello? Is Tasabih available?
Assalamu alaikum.
Wa alaikum assalam. You can start and share your screen.
Okay, just a minute.
Let me try to make you co-host. Yes, you can share, I think.
عايزة أعمل أفتح الكاميرا.
Try to share it. I make you co-host. You can share now. Are you able to share?
Yeah, just a minute. Okay.
Okay.
Share.
Now I want to share. So meeting time. أنا ما قادرة أعمل share.
You can't?
Okay.
Share from slide.
You are co-host now. If you try to share, you will find it.
Okay. Okay. Okay,
Very
so
good.
for you.
Yes, we can see very well.
Okay. السلام عليكم. صباح الخير. Welcome to day 2 of our symposium. Now we will talk about the breast implant. The type of breast reconstruction. We are going to talk about the purpose of use, placement, size.
Sorry, Tasabih. Would you make the screen bigger in full
Okay.
share?
Okay.
Yes, that's better.
So
Yes,
we
you can
are going
continue.
to talk about the purpose of uses, placement site, type of breast implant, normal appearance of implant in the mammogram, ultrasound, and MRI, and the common complications. The breast implant is a type of breast reconstruction and is the most common type uses nowadays. It is prosthetic devices like placed inside the breast either to reconstruct or enhance the breast sizes and shape. The purpose of uses are for cosmetic augmentation or post-mastectomy reconstruction and for correction of congenital anomalies. Here in our image, when we do the breast implant, the implant either placed in anterior to the pectoralis muscle or behind the pectoralis muscle. When become anterior to pectoralis, we call it preglandular, and if behind, it is retropectoral. Okay, this is the site of placement. Our images here. This diagram explains the pectoralis muscle and the placement of the implant. And this is a mammogram appearance of retroglandular and retropectoral breast implant. The type of breast implant, either saline implant or silicone gel implant. And the saline implant is filled with sterile salt water. Okay, and in the silicone, it fills with the silicone. This is mammogram appearance of breast implant. Normally, we see the implant round or oval shape with a smooth, regular texture. And we notice that the silicone implant is more denser than saline implant. The silicone in the left of the screen and the saline is in the right. Silicone is more denser, and we can see also the valve with the saline implant, which is not seen in the silicone implant. On ultrasound, we can see in both the echogenic shell of implant, but in the saline become anechoic, homogeneous anechoic content. And in silicone implant, it become homogeneous but hypoechoic, less darker than the saline one. This image explains the normal anatomy of the breast implant. We see also here the homogeneous content of the implant and the echogenic shell. With the left screen A, we see the fold with a mild amount of fluid, which is normal finding in the breast implant. MRI appearance is the gold modalities to evaluate the breast implant because there is a combination of sequences can be used to detect the complication. We know no need for gadolinium contrast to evaluate the breast implant. Commonly, we use T2 to see the good anatomy and silicone-only image. Silicone-only image here is a stir image in which we suppress. There is fat suppression with water suppression. So only we can see signal from the silicone material. The water only, in this image, we can suppress the fat and also the silicone, and we can see the signal from the water. And it is used for evaluation if there is any collection surrounding the implant. Here, this image explains T2 silicone only implant and water only implant. In MRI, there is a little difference in the saline and silicone implant. We see the saline is more bright in T2, and the silicone in T2 become isoechoic or little hypoechoic to surrounding breast tissue. So we find normal findings in the breast implant. We must know it to differentiate between the normal findings and complication of the breast implant. The normal findings like a radial fold. A radial fold is the normal fold, inward folding of implant outer shell that is often imaging like MRI and ultrasound we see in it. While it appears as line extending from periphery into the implant substances. We must differentiate this one because we have also complication sign like teardrop sign, commonly mimicking these normal findings. In the radial fold, we cannot see any silicone inside this fold. Between the two layers, no any silicone. When this radial fold become prominent, it associated with capsular contracture, which is a benign complication of breast implant. The second normal sign is capsular calcification. Okay, here this is ultrasound and mammogram and MRI for implant for radial fold. Here we see the linear density inside the implant. We notice that there is no any silicone material between this fold. This is calcification, also normal finding in the implant degeneration. We see it in X-ray, CT scan, mammogram, and ultrasound. In the ultrasound, we see this calcification with snowstorm appearance. This sometimes mimicking the snowstorm appearance for breast rupture. We must differentiate between both. So when we go into our complication of breast implant, we have early complication and late complication. The early complication like infection, pre-implant collection, including seroma, hematoma, and abscesses. The late complication, maybe like capsular contraction, implant rupture, or serious complication, but it's most rare. It is occur late, like breast implant associated anaplastic large cell lymphoma. So firstly, we talk about pre-implant collection, which is happen early. This is like seroma. Seroma is fluid collections that occur around the implant, usually within first years of implantation. In ultrasound, it appears as anechoic or hypoechoic fluid surrounding the implant. In the MRI, it follows a sequence of water. It is hypointense in T1 and hyperintense in T2 sequence. Here's this image for seroma. In the right, we see this is implant and partially appear capsule. This is not capsular rupture. This is partially appear capsule with peri-implant anechoic collection. On MRI also we see axial T1, T2, T1 and sagittal stair image. All of them explain this is peri-implant fluid collection. The late collection occur also is breast implant associated anaplastic large cell lymphoma. It is a rare form of primary breast lymphoma that has primarily been associated with textured breast implant. We have two types of silicone implants, smooth surface and textured surface. The textured surface is commonly associated with this breast lymphoma. This is unlikely to occur with or rarely occur with a small surface implant. Commonly, patient manifest with pre-implant effusion, but less commonly to see the mass with or without effusion. Commonly present with this effusion. The ultrasound for diagnosis, ultrasound is first line modality. Then the MRI is golden modality for the detection. Mammogram have less specificity and no specific finding in the mammography. Here in ultrasound, we can see this is peri-implant fluid with 6 septation, and also we have solid component within. This if we see it lately after the breast implant, it must be aspirated and investigated for the breast lymphoma. The rare findings is the mass, which is seen downstairs in the maximum intensity projection, and in sagittal fat separation T1, we can see this is mass in the lower inner quadrant. A common complication also we have capsular contraction. The capsular contraction is potential complication of breast implant and refer to tightening and hardening of the capsule that surround breast implant. It's conditions that can distort the shape and cause pain in the augmented breast. It seems to be the most common complication post-breast augmentation surgery. In the mammogram, we see here, we know the left breast, the implant is becoming spherical in shape comparing to the right. So the capsular contraction can distort and change the shape of the silicone. And as we see in the mammogram, the left one become more rounded than the right one. Here in the ultrasound, we can see also the prominent folds that indicated of capsular contraction in the left of the screen. And in the right of the screen, we can see the capsular thickening. Also, it is a sign of breast implant contraction. Okay, in the mammogram appearance, we can see very thick, hypointense fibrous capsule and round or distorted implant shape. Here, this is T1, T2. We see all of them, we can see the hypointense thick capsules. This is a sign of also of capsular contraction. The second common complication, which is late, the capsular rupture. The breast implant rupture are recognized complication of breast implant. It can be intracapsular or extracapsular. The intracapsular one confined by surrounding fibrous capsule. Extracapsular when silicone is freely extravasated. In the intracapsular rupture, first we're talking about, intracapsular rupture, we can look for some sign to look for to differentiate between the intra and extracapsular rupture. So we can see first sign is subcapsular sign. Subcapsular sign is parallel line within the content of the breast implant, not following the outer envelope capsular complex. And the second sign is step leader sign. Small layers of parallel line within the content of the implants. And also we have teardrop sign and keyhole sign. Also this sign is differentiate the intracapsular from extracapsular rupture. Here we have imaging in the ultrasound and mammogram explain this sign. The first one is subcapsular sign. We see this is parallel echogenic line not following the envelope capsular complex, and more layering and folding is called step leader sign. On the MRI, we can see this sign, the keyhole sign and teardrop sign. The teardrop sign, it is the most mimicking with the normal breast fold. The difference is there is the wall of implant touch each other, but we find a little amount of silicone inside that it differentiates it from the normal fold. And also we have keyhole sign, also is called nose sign. The walls is not attached to each other, and we find also the silicone between in this space. This is also MRI appearance of intracapsular rupture. If the rupture is minimally collapsed, we can find the parallel line called subcapsular line. We see it previously. And when the rupture is significantly, we can see more layering, curvilinear layering. We can call it linguine sign. Linguine sign, it is a sign of intracapsular rupture when it becomes more significant. The second type of implant rupture is extracapsular rupture. Extracapsular rupture can lead to change in implant contour and may be detected on clinical examination or by mammography. Here our mammogram for saline and silicone implant. In the left, we see the left breast mammogram. We see retroglandular saline implant with rupture implant in the left breast, and also left breast rupture, extensive silicone outside or within breast tissue in the left breast. The ultrasound appearance of extracapsular rupture. This ultrasound, we see the silicone beyond the capsule and causing stochastic shadowing called snowstorm, or we call it dirty shadow. This must be differentiated when there is extensive calcification that causes the same shadowing. We must differentiate between this sign of extracapsular rupture and calcification mentioned before. The extracapsular rupture sometimes accompanies with a deposition of silicone in the axillary lymph node, which cause same snowstorm shadowing in the axillary lymph node. This is in the right image. We find this sign. The appearance of extracapsular rupture in the mammogram, we find also here in silicone selective image. We see hyperintense extravasation of the silicone anterior to the right implant. Also in T2 fast spin echo, we find also iso-intense extracapsular silicone rupture outside the breast. This is a sign of extracapsular rupture. Thank you. Any question?
Amazing lecture. Very informative.
Amazing
and to the
presentation.
point.
Thank you. Thank you. Welcome.
Thank you very much. Thank you very much. That was insightful and amazing. So, any questions from the audience? We have discussion at the end, but just to let Dr. Rabab or anyone who want to just give a small note. Okay, so
maybe I could not add
Dr.
a lot
Rabab,
because of
your
my
voice is not clear.
I lost my voice because of the virus infection that I might not contribute a lot. Sorry for that. Give me
sorry for that, no
excuse.
problem. Sorry for that. So we can move to the so now we will thank you again, Tasabih. Now we will move to the next presenter, who is Rabab Osman Abdurrahman Ali. She will present breast density assessment. So Dr. Ali, Dr. Rehab, sorry for the mistake. Dr. Rehab holds MBBS from Kasal University and MD from, let me share the presentation for you to give you the insight. Is my screen shared? So the next presenter is Rehab or Fatma, because it is in the schedule is Rehab. Who is going to present next? Is Fatma available? I'm sorry, so who is available for presentation next?
What next?
Rahab is not available. Rahab in Sudan. Might be network.
No problem. So is Fatma available?
Fatma, are you there? Fatma Mukhtar.
So who want to present after this? Who is available? I can just present. Dr. Yusuf. No. So what you suggest, Dr. Rabab? Because two presenters are not available. Do you want to
The questions, open it for the questions.
discussion?
Discussion, yes. Discussion
Okay.
with the two previous
Presentations?
presentations, yeah. Dr. Hiba and Dr. Tashabi. If there are any questions for them, read it for them to answer.
Okay, so
And
now
if
I have a question. I will start.
Ask,
I will start my questions to Dr. Hiba. So Dr. Hiba, are you
Yes.
doing automated contrast for every dense breast in the screening, or what is the usual practice for you to use automated breast ultrasound?
The protocol is if the patient came for the first time for screening, we do the screening, and like if we have available and her density is C or D, and we have a available slot, we can do the automated breast ultrasound or call her or give her appointment for the automated ultrasound. And next year, because we already know that she is either C or D, we book her for both together for
So
every
symptomatic.
patient. No,
So now,
symptomatic is different. So this is
okay.
the ABIS is just a screening tool. So only for screening. If the patient is symptomatic, that is go under the diagnostic track. The diagnostic track is usually is diagnostic mammogram and handheld ultrasound to the area of concern.
Good. Thank you.
And if the patient is very dense, we can, like at that time, we can either do full screening bilateral breast ultrasound, or if we solve her problem for now, we can book her for automated breast ultrasound in like as soon as available.
That's very insightful, honestly. And it's
Okay,
very,
thank you.
very good with dense breast. Yes, Dr.
It
Rabab,
is.
forward to you.
Yeah, so you are doing targeted ultrasound, handheld ultrasound as a targeted one, yes? Only.
That is if the patient is symptomatic and came for diagnostic
Yeah,
ultrasound.
yeah,
And
yeah.
yeah.
What I mean when you are using handheld ultrasound, you are doing as targeted. Whatever the patient presented with
Some,
as
yeah.
symptomatic, or you find on a screening tool.
We use it as a screening tool
Problem.
also. Yeah. So like
You
we
are
use it.
using handheld as screening also.
Yes, so some
Good.
patients they're very like there is limitation for the automated breast ultrasound also. If there is extensive calcifications, so much shadowing, if the patient has like a portacath or a
You
pacemaker
want to adjust.
that prevent
You want to adjust the ultrasound.
exactly.
More adjustment.
Yeah,
You need to go for handheld ultrasound.
yeah, yes, but
I use
very rarely we use it because
mm,
like the automated breast ultrasound, it's reproducible. So you have the whole breast scanned. It's not operator dependent. And if you see a lesion, like in the handheld, if the technician did not see the lesion and she did not take presentative images for the lesions, you don't know that this lesion exists before. But for the
yeah,
automated breast ultrasound, it's
definitely.
exactly like the CT. All the
Yeah,
images are there. You can compare them.
yeah, and like mammography and tomosynthesis, you'll
Exactly.
find the lesion. You'll
Yeah,
find the lesion.
exactly.
That is, yeah, I agree with you. I have no experience of automated ultrasound, only from literature, but I used to use handheld ultrasound on screening, and on my experience, rarely use automated handheld ultrasound as targeted. only second as after MRI, we call it a second look, as a second look ultrasound. Okay. Otherwise, I used to use bilateral screening
For
ultrasound
every breast or for
for
the
for
density C or
all
D?
for all of my patients. In my experience, I used to do bilateral ultrasound for the whole breast and axilla as well. And I have a lot of cases detected only يعني young ladies. I remember one of my cases. It was 22. I cannot forget this lady. She has segmental ductectasia with bilateral segmental ductectasia with calcifications. With ductal calcifications reported, and she was unmarried, reported as mastitis. Brought to me, يعني she came to
Yeah.
me on follow-up, and it was suspicious,
Yeah.
and recommend biopsy, and it was bilateral invasive cancer. She was 22-year old, and she had when she came for the follow-up as mastitis, I'm the one who had done for her the ultrasound. You see, and she had at that in the first ultrasound she had no axillary lymph node. In the second follow-up, she had bilateral axillary lymphadenopathy, unfortunately. As you know, in young ladies, it's
Yeah,
so
it's very
aggressive,
aggressive. Yeah.
very aggressive. Even on the follow-up, there was no any masses, only ductal disease, segmental ductal, complex segmental ductal disease. But the message is uh, any segmental ductectasia, okay, especially if associated with calcifications, and if it is complex, associated with internal echoes, we have to take it seriously. Even the patient is young. I do remember that the patient was only 22 years old and she was unmarried, and she had bilateral cancer, breast cancer, only presenting as, but because I was doing screening, not only targeted ultrasound. Thank you.
And Rabab, you do the ultrasound yourself, or it's done by
Yes,
the technician? Oh, okay. That's the
even
other thing.
even when the technician do ultrasound, I used to repeat it myself.
Yeah.
I at the beginning when I start, there was no technician doing ultrasound. We are doing the radiologist. But I've worked in another place that the technician doing but they have done a lot of missing.
Yeah, this is the problem.
I do remember one case. I have seen subtle, this patient pushed to do screening from, you see, from her physician. She doesn't like to do the screening. They push her. When she came, she doesn't like. And the technician came to me. I went there and I convinced her to do mammography. And when the technician did ultrasound, she told me there is nothing. When I went there, I found in the extreme upper inner left breast 4 by 3 millimeter hypoechoic lesion, and the only findings, the clue for being cancer, it was what we call it cutting sign. You see, this cutting sign, when we presented long time ago, I have seen it recently in the literature, but we didn't write it. You see, it cuts the tissue. The lesion cut the tissue, though it is very small by that cutting sign, and they could not even biopsy. Those who have done the intervention, I have no experience in doing breast biopsy. Unfortunately, this is my weakest point in breast imaging. But they couldn't catch the lesion. The surgeon came to me and I draw it for him. Okay, and he took the patient to the theater, take it out, and finished. Completely cured. Screen ultrasound 3 by 4 millimeter only. I have a lot of cases missed by the technologists. A lot of cases. I presented
Again,
before.
yeah, again, that brings us to the beauty of the automated breast ultrasound, because
Yes,
it's
you are
not
right.
operator dependent.
Operator dependent. Yeah, yeah.
And the other thing, that if you have multiple lesions that like circumscribed lesions, like symmetrical, bilateral, circumscribed, this is by definition by RATS2, you can easily compare them and follow them on automated ultrasound, and then you can get the similar images and similar measurement every time. And also, like, it's always a problem that when you send the patient for screening ultrasound, and then they keep getting those benign looking lesions, and you get to bring the patient to the cycle of BIRATS 3 again and follow them for the whole 2 years. Now we do just like if it does look like the other lesions, we follow them on automated breast ultrasound. So that is also like decrease the workload and increase the detectivity. As the automated breast ultrasound usually take around 10 minutes for the image acquisition, compared to the handheld ultrasound that is usually around 40 minutes to do bilateral breast and axilla.
Definitely yes. Definitely yes. It is really helpful. Yeah, because it will give overview like mammograph and tomosynthesis, not like ultrasound that if you miss area, not the scan, so you will miss a lesion definitely, especially if it is not palpable.
Yeah.
So it is slightly different here in UK. We don't have automated breast ultrasound. We have targeted ultrasound for the cases of screening. We have assessment clinic for screening recall cases. So we will do further imaging like tomosynthesis, contrast enhanced mammography, whatever needed, or ultrasound and ultrasound core biopsy for the masses if seen in tomo. But we don't have the automated breast ultrasound. I think maybe in the future, if NHS has more funds.
Dr. Latifa, are you there? If you are available, you can share with us your experience. Dr. Aziza, Dr. Latifa, any of our colleagues here will be happy if you will share your experience in this.
This is very insightful, to be
Aspect.
honest.
Yeah.
We need more experiences and more sharing from other practices.
Yeah, I think Dr. Latifa was attending the lecture, but I
السلام
don't know
عليكم
if she's there.
السلام عليكم
وعليكم السلام دكتورة لطيفة. You are welcome.
يعطيكم العافية.
الله
أهلا
يعافيك
دكتورة
دكتورة.
لطيفة، كيف حالك؟
الله يسلمكم. صراحة أنا منبهرة ما شاء الله فيكم، أنتوا وايد نشيطين.
الله يديك العافية. الله يديك العافية يا دكتورة. الله يكرمك يا رب.
فعلا أنا أول
We
مرة
are
أشوف
trying
ناس
to
مسوين يعني مؤتمرين في نفس الشهر.
We used to do like that. One MDT, one radiology.
الله
Radiology
يعطيكم
pure.
العافية.
الله يعافيك. الله
بس
يسلمك.
حاولوا الله يعافيكم السنة القادمة تخلون يعني على الأقل واحد منهم يكون في شهر 11 أو 12، لأن إحنا بشهر 10 نكون وايد overwhelmed، عندنا أنشطة وايد توعوية، فكذي إحنا نقدر نحضر معاكم أكثر يعني.
بإذن الله. نحن
Agree.
الأكتيفيتيز يا دكتورة لطيفة throughout the year. We have we have webinar, scientific webinar monthly, and from the next and we have MDT discussion every month, and from the next year we are going to change from monthly webinar to 3 month symposium, inshallah.
الله
I will
يعطيكم العافية.
I'll give you notes every time, inshallah. You are welcome. We are waiting to share your experience.
بالنسبة حق ال 3D ultrasound أنا كنت قبل practicing في مستشفى مبارك، بس للأسف أنا I like 3D، بس المشكلة فيه إنه هو ياخذ long time، وإحنا أساساً عقب ما نسوي ال 3D we have to go for 2D ultrasound as well. I think إن this is في إذا كان عندك center you are so busy this will waste some time. حاليا احنا عندنا 3D بس للأسف ما اشتغلنا فيه لأن I want to have some training to the doctors اللي موجودين باليونت. ما قدرنا نحصل training من الكومباني. بس أنا صراحة I liked the session today, it was very fruitful وفعلا في cases حلوة.
Yeah, and أنا بس ما عرفت أنت it was the time of the radiologist ولا for the technician you mean?
both لأن أنا في مبارك كان we have full trained يعني team، فأنا كنت أشتغل التكنولوجيست trained radiologist trained، بس أنا اشتغلت عليه فترة بعدين I moved to another hospital. الفترة اللي اشتغلت عليها it was nice بس I feel إن فعلا it takes a lot of time، يعني يبي له واحد يكون dedicated موجود يشتغل عليه متخصص فيه بروحه. بعدين if you have a finding you will bring the patient. أنا لاحظت أنتوا حتى بالمحاضرة كنتوا when you have something in a 3D ultrasound you move to the 2D ultrasound صح؟
Yes, sure. عشان for more characterization of the margins of the lesion. It's a
I think Dr. Hiba, the sensitivity of automated ultrasound is much higher than
much higher.
much higher than handheld ultrasound. But
Yes,
the
حتى في
specificity,
literature it's the same.
but the specificity of handheld in expert hands, not in every hand, in expert hands, handheld ultrasound specificity is higher than automated. Because
Yeah, exactly.
you can sweep through the lesion margins to make sure that is really circumscribed or non-circumscribed and to characterize it further. But for picking up, like giving an overview, like mammography, automated ultrasound, I think if we are familiar with it, we can read it quickly. We are trained, okay? It should not take long time.
Yeah, and for me it takes 3 minutes to read the automated breast ultrasound.
Because you are expert on it.
Okay? Oh yeah, but you develop it with
develop with time. This is what I mean. With time, generally like tomosynthesis. Most of us they have no experience on tomosynthesis. Okay, but with time, for me, I did not expose for tomosynthesis except from literature on my lecture. But recently, I received a lot of tomosynthesis from my colleagues for reading, and I discussed it with them. Now I'm reading tomosynthesis, but I did not practice it in a regular press unit. But now I'm reading tomosynthesis. But I think if we build up experience of automated ultrasound, it will be the same.
Yeah.
For detection,
Agree.
it will be يعني much better than handheld ultrasound. When we saw a lesion, then we'll go for handheld. تفضلي دكتورة لطيفة.
دكتورة هبة, if you are taking 3 minutes and when you are expert in doing 3D ultrasound, ليش you are going to do ليش قاعد تسويه مرة ثانية 2D؟
لأن هي screening tool. We just see lesion, we don't know the margins of the lesions, and we don't know the vascularity or posterior acoustic features of the lesion. So we need to do a 2D عشان to characterize the lesion عشان to get it either by RAT 3 or by RAT 4. So that can be easily done at the same setting. نحن بس عندنا مشكلة إنه when we do the screening, a radiologist they do another thing. We do diagnostic at that time. وبعدين we read the screening as batches, like in a different time. لكن يعني if you want to manage the time, or you want البيشنت تجي مرة واحدة, you can do a mammogram and screening automated breast ultrasound. Have a look at the screening automated ultrasound, and then if you see lesion حتقولي للتك في نفس الوقت. Yeah, I see lesion at 11 o'clock left breast. Go have a look at this lesion. You will take 2 minutes to look at that, because you know where is the lesion and what is the distance from the nipple, and she will give you a presentative images, and the whole thing, it will not take the patient the technician more than 15 minutes to do, because like we take three images for one breast, lateral, anterior, posterior, and medial. This take every set of image take around 1 minute, 1.5 minutes. So for the one breast, it's around 5 minutes, and the other breast is 5 minutes. And if you see abnormality and you add looking for one lesion, that will take 2 minutes, in a total of 12 minutes, rather than 45 minutes doing handheld screening ultrasound for the dense breast.
Dr. Latifa, it is this scenario is the same like as you are doing mammography, screening mammography, and you have seen something, then go for targeted ultrasound to do diagnostic scanning. It is the same way. You see, complementary for tomosynthesis and for mammography. Instead of only doing mammography, especially in dense breast, doing mammography, screening mammography, complemented by screening automated ultrasound. So the detection rate, it will increase. Looking for the lesion and recall the patient, or if the patient available at the same setting, you will shift the patient from screening to diagnostic when you do a handheld ultrasound. Am I right? Am I correct, Dr. Hiba?
Yeah, correct. And it is very, very time efficient. It's like we tried both, but this is really saving a lot of time, and then and also save us like for the diagnostic, like for handheld ultrasound, even if you're doing it for screening, it should be supervised by a radiologist, and to prevent those like operator dependent errors. But for the automated ultrasound, there is no room for that. So it's, yeah, the missing could be from the radiologist, but you know that the lesion is there in the images somewhere, and with the experience you will find it more easy.
And then what about the axilla? If the screening was normal, would you do 2D for the axilla, or you don't?
No, we don't know.
We don't. Okay. Thank you.
There are a lot
Hiba?
of protocols regarding axilla, I think. It depends on the center, the examination of the axilla.
Every patient we bring for assessment screening, and we find something, calcification or anything, we should do axilla before doing the next step. And if it is ultrasound, definitely we'll do axilla. So definitely you have something like that.
No, I mean, if the patient came for screening and the screening is negative, we don't do the axilla. But if there is anything, whatever the thing is, we do the axilla. Like, because we're doing a handheld now, but for the screening, it will not reach the axilla for the automated breast ultrasound.
This is one of the drawback of automated, is not examining the axilla yet. They are not adjusted to examine the axilla.
It will, if there is axillary tail, it will reach there, but not the axilla.
Not the deep axilla, not the deep axilla.
No.
Yeah. This is one of its drawback. Yeah.
Dr. Hiba, thank you for the great presentation. I have realized that the 2D has more in the resolution and characterization is better than the automated. Maybe that is why you do complementary 2D after.
Yeah,
all the
exactly. Exactly. So now, like we detect the lesion on the automated, and then now we want to characterize the lesion. Is it likely benign? It's BIRAT 3, or it is suspicious BIRAT 4, and we can go for the biopsy. And in that when we bring it for the handheld, we look at the axilla.
Thank you so much.
So Fatma is now available. So I want to excuse you. We have a break after the discussion, but Fatma is from the morning session. So if you agree, we can proceed with her session. Then we will do the break after that.
Yes, we agree. It's better.
Okay. Yeah.
Yeah.
So let me just go back to Fatma. So moving now to a specialized area, we welcome Dr. Fatma Mukhtar Abdel Fatih Youssef. She is MD from Sudan Specialization Board and a senior registrar at Al Adan Hospital in Kuwait. Her topic is pediatric and adolescent breast imaging. Please proceed, Fatma.
She's working
Assalamu
with
alaikum.
Dr. Latifa. Huh? Dr. Latifa is the head of Adan Hospital, and Dr. Fatma is working in her department.
Nice to know that. Thank you.
Assalamu alaikum.
Wa alaikum assalam. Just let me make you co-host. Yes, you can share now, Fatma. So after I will, the co-moderator will be sharing the break period after me because I have something to do in half an hour, and I will be back. Thank you very much. Over to you.
Okay. Assalamu alaikum.
You can share now.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
We can start our topic, pediatric and adolescent breast imaging. Now I will sharing my screen. Clear now? The screen is clear now?
Yes, Fatma, continue.
Okay, we are starting our topic. Bismillah ar-Rahman ar-Rahim. We have to introduction. Breast masses in children and adolescents are uncommon. A breast lump in a child may be a source of concern to the patient and their families. The spectrum of mass-forming breast lesion in pediatric patients is different from that in adult, and the vast majority are benign, with only 0.2% of primary breast cancer arising in pediatric patients. In the breast lump in the children and adolescent include normal breast development and developmental variants, inflammatory and traumatic, and tumors, benign and malignant. We will discuss this, inshallah, separately. We are talking about normal breast development. Here we have breast tissue develop at approximately starting at 5 weeks of gestation, arising from ectoderm to the ventral cervix along curvilinear ridge known as milk line. This line we known as milk line, extending from axilla to groin, and the milk line disappear after formation except for at the anterior fourth intercostal space. يعني this line will disappear and only at the fourth intercostal space. As we said, it is start at the 4th week and end at the 12th week. Start with primary mammary bud. It is start with primary breast bud, then with secondary breast bud, and then branching, and then lastly form lactiferous duct at the 12th week.
We're discussing the abnormality in the embryogenesis and development. Here we have abnormality in development. We have the polymastia, accessory breast tissue in the right axilla, MRI, axial T2, showing accessory breast in the right axilla. Also here, we have an accessory breast, polymastia, accessory breast with the nipple. Here we have nipple and underlining breast tissue on ultrasound also. We have another term called polythelia, which is accessory nipple without underlining breast tissue. Here we have accessory nipple, and an MLR view, we have an accessory nipple without underlining breast tissue. Also, in an abnormal development, we have asymmetrical breast bud development. Rule in our ultrasound to provide verification that normal breast tissue is present and to exclude any underlying mass, and reassuring for both patient and the parents. Here we have a 9-year-old girl with palpable left breast lump on ultrasound. We have left breast showing. We have discussing tenor stage later, inshallah. Here we have breast with tenor stage 1, and on the right side with the tenor stage 2. It is asymmetrical, but it's normal. So we're discussing pubertal breast development. What is the CLARC? Onset of breast development. هو onset of the breast development, first sign in pubertal in girl, typical age 8 to 13 years. We have a CLARC at 8 to 13 years with starting with tenor stage 2. What is the premature CLARC? Isolated breast development before age of 8 without other sign of puberty. This is important to differentiate premature CLARC from previous puberty. What is the difference between premature CLARC and previous puberty? Two of them start as breast development before 8 years. And on ultrasound, the same finding, but we have to differentiate it clinically with other sign of puberty. In premature CLARC, no other sign of puberty, but in previous puberty, we have another sign of pubertal sign like pubic hair, rapid growth, and bone age advancement. What is the delay CLARC? Is the no breast development by age of 13 up to 14. Then if the girl no sign of CLARC at age of 14, we should be investigated. And what is the early CLARC? Difference between early CLARC and premature CLARC. Early CLARC breast development at the lower end of the normal age. Typically between last age, typically between 7 to 8 years, especially in girl of ethnic group like African. This is the normal. 7 to 8 years with family history and girl with good bodybuilding. This is called early CLARC. We are talking about tenor staging. In tenor stage 1, we have to discuss clinically and on ultrasound. How it appears clinically. The breast clinical elevation only of papillae, only elevation of the papillae clinically. On ultrasound, we have hyperechoic retroareolar tissue here. Okay, and this is its pre-pubertal stage. And stage 1 is the pre-pubertal stage. This is an example of 8-year-old girl with ill-defined hyperechoic area here in the retroareolar zone. In tenor stage 2, clinically, we have elevation.
There is background noise. Would you please close your mic, everyone? Would you please close your mic, everyone, to avoid background noise?
In tenor stage 2, we have clinical elevation. Still, we have background noise, sorry.
Fatma Brahim, please. Fatma Brahim, would you please close your mic? Fatma Brahim. ولكن okay.
Okay.
Yeah, you
internal
can
step 2, clinically we have elevation of both breast and papilla. Okay, with a small lump. يعني clinically we have elevation of breast and papilla with a small lump, but it's confined to nipple areolar complex. Or no evidence of areolar elevation, and should not exceed 2 centimeters. Okay, on ultrasound, we have a star-shaped hypoechoic area surrounding by hyperechoic area, but it should not be exceed 2 centimeters. Okay, يعني internal stage 2 we have elevation of both breast and papilla, a small lump, but it's confined to nipple areolar complex. No evidence of areolar elevation. On ultrasound, we have a star-shaped hypoechoic area surrounding by hyperechoic area, not exceeding 2 centimeters. And this is example of 9 years old girl showing hypoechoic area surrounding by hyperechoic area not exceeding 2 centimeters. Internal stage 3, clinically we have nipple retroareolar complex but no elevation of the areola. يعني we have palpable lump but no elevation of the areola, same contour and no mound. Okay, this is differentiated from stage 4. يعني we have breast lump without elevation of the areola. On ultrasound, we have an obvious enlargement. We have a spider shape, central spider shape, hypoechoic area surrounding by hyperechoic area exceeding 2 centimeters. In stage 2, not exceeding 2 centimeters. In stage 3, it is exceeding 2 centimeters, not exceeding 3 centimeters. Okay, this is 13 years old girl, consistent with standard stage 3, spider shape, hypoechoic area surrounding by hyperechoic area not exceeding 3 centimeters. On tenor stage 4, we have elevation of both breast and areola with a mound, with separation of their contour. And on ultrasound, we have hypoechoic area surrounding by hyperechoic area exceeding 5 centimeters. Okay. This is an example of tenor stage 4 prominent peripheral hyperechoic preareolar glandular tissue with central spider shape hypoechoic area exceeding 5 centimeters. On tenor stage 5, clinically it's similar to adult breast. Okay, and in stage 5 we have an adult breast, increased subcutaneous adipose tissue, and we have a central spider shape is no longer visualized. يعني central spider shape or hypoechoic area is no longer visualized in stage 5. It's only appeared in stage 2, 3, and 4. Now we have hyperechoic glandular tissue with fine scattered hypoechoic spot. This is an example of tenor stage 5 hyperechoic glandular tissue with fine scattered hypoechoic spot and increase in subcutaneous adipose tissue within the gland. Here we have adipose tissue within the gland. We are discussing premature thelarche. As we said, it's onset of female breast development by age of 7 to 8 years. At sonography, it appears as normal breast development without discrete lesion. We have to exclude any underlying lesion. Here we have bilateral retroareolar heterogeneously hypoechoic area more prominent on the right side. Here we have 6 years old girl with unilateral breast lump. On this, we have a left breast with tenor stage 2 and right breast with tenor stage 1. And this is represent in 6 years old girl. It represents premature thelarche. Radiological evaluation for suspected previous puberty should include, and this is, as we said, this is a difference between premature thelarche and previous puberty. We should investigate the patient with bone age assessment, abdominal and pelvic ultrasound. يعني we recommend this investigation for any evidence of maturation of uterus and ovary, in addition to evaluate for estrogen producing lesion. طيب, gynecomastia is excessive development of breast tissue in male patient. In the pediatric population, it can be physiological or pathological. Physiological gynecomastia is generally seen in three groups, okay? In neonates and adolescents, and in men. We are discussing this gynecomastia in this session in neonate and in adolescent. Neonatal breast hypertrophy, common transient condition seen up to 90% of all newborn, both male and female. It presumed to be caused by transient elevation in estrogen due to transplacental passage of the hormone. So male and female, it's the same at this age. It's usually seen in the first week of life and resolves spontaneously within the few months to 2 years. It is important that this condition begin before 6 months. It's end up to 1 year, up to 2 years. It will be resolved spontaneously. Here we have physiological neonatal breast enlargement in 5 years old infant, male infant with palpable left breast. It shows an enlarging left breast tissue. Now we are discussing the neonatal gynecomastia. Now we are discussing prepubertal gynecomastia or pubertal gynecomastia. Here in the prepubertal, this diagram is show prepubertal stage in both male and female. It is start identical. Then in the female, when hormone and estrogen lead to ductal proliferation and branching, and then with progesterone lead to lobular proliferation. In male, when in the puberty elevated testosterone level, this causes ductal involution or atrophy. If any hormonal imbalance between androgen and estrogen in male patient, resulting in ductal proliferation and lead to lobular proliferation as in female. Different radiological pattern of gynecomastia. We have nodular button or fan shaped subareolar tissue and dendritic or flame. This is flame shaped subareolar breast tissue, and there is another type. Third type is diffuse button, as in female breast with heterogeneously dense breast. Here we have in this nodular type, and this is dendritic type, fan shape, and this is diffuse type like breast female with diffuse fibroglandular tissue.
عكست يا فاطمة هنا دقيقة. The left one is nodular and the right one is diffuse.
Yes. This is the nodular, and this is dendritic, and this is diffuse type. Here we have a male adolescent breast, 18 years old male with breast with two breasts with the fan shape or dendritic type, more on the left side, consistent with nodular gynecomastia. We have pseudogynecomastia referred to breast enlargement in men due to fat tissue but no associated glandular or stromal tissue. Yani here we have patient came with bilateral breast lump. On ultrasound, there is no detectable glandular tissue, only fatty tissue, and this is called pseudogynecomastia. Here we have also bilateral prominent fatty tissue, no detectable glandular tissue. We are talking about benign pediatric breast mass or common breast mass in pediatric patient. We have to consider mastitis and abscess. In pediatric patient, mastitis commonly affect infant in the first 3 weeks of life. We call this mastitis neonatorum, and it appears as increased parenchymal heterogeneity and echogenicity, and may be focal or diffuse, associated with hyperemia at color Doppler ultrasound with overlying skin thickening. We have an example here of 4-week infant with left breast enlargement and redness. On ultrasound, we have heterogeneously enlargement of the breast with peripheral hyperemia. Also, we considered vascular masses and infantile hemangioma. It is rare to be occur in the breast, but it can be happen. It's like ordinary routine hemangioma. We have benign vascular neoplasm, have a predictable life cycle and traditionally absent at birth. يعني typical sequence of hemangioma with rapid growth in the few weeks of life and months. This is the proliferative phase, followed by spontaneous regression, a involuting phase at 12 months of age. On this ultrasound, we have heterogeneously, this occurs in the axilla. We have heterogeneously tissue mass. Here we have with marked vascularity. Okay, and this is IV contrast enhanced MRI of the mass. Avidly enhancing mass, and this is follow-up MRI with significant regression of the mass. يعني typical history, we have proliferative phase and evaluating phase of hemangioma. Also, we considered lymphangioma is a benign developmental lymphatic tumor. Vast majority present before 2 years of age. While lymphangioma most common found in the neck or axilla, it can also occur in the breast. On ultrasound, lymphangioma appear as multiloculated avascular cystic masses with septa of variable thickness. On MRI, lymphangioma appear at T2 hyperintense and lack of contrast enhancement. Here we have a 20-month-old boy with palpable right breast show cystic mass with multiple thin septa. On axial MRI, this mass T2 hyperintense, corresponding with lymphangioma. We have to consider trauma and hematoma in pediatric patients. And if the patient came with hematoma on the right breast, or foreign body, or like this, we have also to consider non-accidental injury for the patient. Okay, like in this is the patient. We have another example, and this is the patient of 17 years old with subcutaneous after placement hematoma after placement of subcutaneous central venous catheter. On color Doppler, we have heterogeneously mass on the heterogeneous avascular mass of the right breast with hyperechoic linear structure. This is the central venous line, hyperechoic structure consistent with central venous line. And this is the CT for the same patient showing hyperattenuating hematoma of the right breast with active hemorrhage. We have to consider, as we said, for foreign body. This is the patient, 9 years old boy with here we have linear echogenic foreign body consistent with spine. Fibroadenoma, most common cause of solid mass in the pediatric population. Mean age at diagnosis 15 to 17 years. And fibroadenomas are estrogen sensitive and may grow rapidly during puberty and pregnancy. This is an example of fibroadenoma in 16-year-old girl present with right lump. Ultrasound show homogeneously hypoechoic mass with margin and with posterior enhancement. Juvenile papillomatosis is a rare localized proliferative disorder of multiple papilloma present in peripheral duct, and adolescent and young adult women are affected, and mean age is 19 years. On ultrasound, papilloma show irregular complex hypoechoic mass with internal cystic spaces. This is the grayscale ultrasound, ill-defined hypoechoic mass with innumerable cystic spaces. On MRI, we have an irregular right breast mass containing T2 hyperintense cystic spaces. Malignant pediatric breast Primary breast cancer is rare in pediatric breast and associated with inherited genetic mutation like BRCA1 and BRCA2. Breast cancer is to occur secondary to childhood treatment malignancy like Hodgkin lymphoma. And primary breast cancer is rare, alhamdulillah, is rare in the pediatric population and maybe come from other treatment of malignancy like Hodgkin lymphoma. This is 17 years old girl with enlarging left breast lump, showing irregular hypoechoic mass with angular and indistinct margin, and on maximum intensity projection, it show irregular homogeneously enhancing mass. Metastatic disease هي most common cause of malignant breast mass in the pediatric patient. يعني primary breast cancer is rare in children, but metastatic breast mass هي common cause of malignant breast mass in pediatric patient. Most common frequent primary malignancy that metastasis to the breast include rhabdomyosarcoma, non-Hodgkin lymphoma, and leukemia. Breast mass are more frequent in female patients, but can occur also in male patients. This patient, 15 years old girl with rhabdomyosarcoma, ultrasound showing irregular hypoechoic mass with indistinct margin here, and on PET CT scan increase radiotracer uptake within the mass, and contrast enhanced MRI show large irregular enhancing mass occupying most of the breast, representing metastasis from the non-primary rhabdomyosarcoma. Okay, thank you. Any question?
Excellent, very informative lecture. Excellent, Fatma.
Thanks, Dr. Rabab. Thank you.
Excellent, excellent, amazing. Yani,
Thank you.
You presented in very nice way. Just to summarize the developmental, okay, as Dr. Fatma mentioned, just as she mentioned, the rudimentary ducts after the baby delivered, okay, it has just a rudimentary duct, okay, representing tenor stage 1. And if there is surge, if there is surge from the mother hormone, okay, through placenta, or the drop in the hormones stimulate the pituitary of the neonate, might result in the development of a neonatal gynecomastia. And this is to be diagnosed as neonatal gynecomastia, it has to start before the 6 months. It can be in the first week up to 6 months. If you start before that, then we call it neonatal hypertrophy, breast hypertrophy, or neonatal gynecomastia, which present with bilateral, usually bilateral, but it can be unilateral or can be bilateral asymmetric in both girl or boys, okay, and can be associated with milk discharge or even with blood discharge, okay, just to reassure the patient and to follow it. And it will usually disappear by 9 months, but it can stay up to 2 years. This is the neonatal gynecomastia. If it is not after, if it starts after 6 months, then this is not a neonatal gynecomastia. Then we are starting to call it premature SLAC. And as we mentioned before, at the age of 2 years, there is physiological surge of the pituitary hormones. And this can also result in breast enlargement equally in boy and girls. And it would be transient and it should be disappeared. if it not disappeared, then endocrinologist should be, we should recommend to be seen by endocrinologist for further evaluation for endocrine problem. So from the age of 6 months, okay, up to the age of TILARC, which is commonly or usually 8, this period, any breast development, we call it premature TILARC, premature TILARC. But as he mentioned, Fatma, it depends on the body build and ethnic group, and these, the TILARC might start earlier before the age of 8. It can be, but before 7, we have to consider it as premature TILARC. But from 7, it can be just as early development of the breast or early TILARC, and it should not exceed Tanner stage 2. If we saw, or if we see Tanner stage 3 at age of 7, we should not consider it as just early TILARC. This is premature TILARC, and we have to recommend further evaluation to exclude precocious puberty, and we might recommend endocrine endocrine evaluation for any endocrine problem regarding this early development. Okay, from 7 o'clock, as we from 7 from age of 7, yeah, we can consider it as early TILARC. From 8 to 12 or 8, commonly from 8 to 7, this is the age of TILARC, normal TILARC, and it should be, or it's usually the first sign of puberty, and can be up to 13. If it is beyond 14, no TILARC, then they have to seek endocrinologist to evaluate for the reason why there is delay in the TILARC. Okay, and if associated, if she mentioned, as she mentioned, if there is pubertal hair or other bone growth abnormality, then we have to consider, or uterine development, premature uterine or ovarian development, then we have to consider it, or we call it precocious puberty, and definitely here this is abnormal and should be evaluated by the endocrinologist. And one point important, usually the TILARC started as asymmetric, and that is most commonly the girl presented with a unilateral palpable abnormality, and usually it is tender palpable abnormality. The growth of breast, as in lactation and pregnancy and lactation, they have tenderness due to the glandular proliferation. In the TILARC, they have tender palpable abnormality due to development of the breast bud. And just we reassure the parent, okay, and we can just follow that. And usually when you check, you might find in the other side, you might find bilateral asymmetric like Tanner 1, Tanner 2, or Tanner 2, Tanner 3, okay? And as she mentioned, it depends on size. A Tanner 2 should not exceed the nipple areolar complex. It will grow just within the nipple areolar complex, while Tanner 3 extend beyond, but not too much, okay, up to 5 centimeter, and Tanner 4 is still not occupying the whole breast, but it is larger than 5 centimeter. When it become mature, it will spread throughout, okay, and now we have no the dendritic appearance of ductal pattern radiating from the nipple. We will see just echogenic tissue with scattered oval, uniform size, uniform pattern of oval isocoic structure representing the terminal duct lobular unit, and this is the mature breast is spread throughout the breast with proliferation of fat lobule within the parenchyma itself and the development within the subcutaneous fat, but still there are variation. Some ladies, they have the glandular tissue occupying the whole breast with paucity of the subcutaneous and retromammary fat. I hope I could explain it for you in more detail. Thank you, Fatma. You did well.
Okay,
If you have
thank you,
questions,
Dr. Rabab.
okay. If you have
Thank you very
questions,
much.
okay.
Thank you very much. That was useful.
One more point. She
Yes.
mentioned, Fatma explained to you, there is elevation of the papilla up to stage, ternary stage 3. Okay, bulbable abnormality is a breast tissue and only elevation of the papilla. While in stage 4, there is elevation of the papilla as well as of the areola, what is called double mount, yes, or areolar mount. You have 2 elevations, and this, it should be recessed. It should be go back on stage 4. If it failed to go back, this mount, the breast might grow through this mount, and it will hinder the spread of the breast tissue and can result in what is called tuberous breast. We have seen before. Okay, this is one important point also. And regarding the male breast, as we mentioned, they have rudimentary ducts, and the progesterone in female that responsible for the development of the gland of the terminal duct lobular unit. But the male, because they have no progesterone, usually they have no terminal duct lobular unit and they have no lobule generally. That is why fibroadenomas and lesions related to terminal duct lobular units are not commonly seen in male breast. They have, if there is hormonal imbalance, they might have very few glands, very few lobules in male breast. Generally, they have no lobule. If they have imbalance, and this is generally occur in pubertal period, result in pubertal gynecomastia. Okay, and just usually it is development and proliferation of the ductal system from premature to mature ductal system, and also can occur in elderly. They have in elderly patient, they might have also some disturbance in hormone, or it might be related to other types of drugs or some diseases associated with gynecomastia or malignancies, such like that. And generally, as also we reassure the patients, and she mentioned the types of gynecomastia. She explained it very well. Thank you very much.
Thank you very much, Dr. Rabab. That was a very useful discussion. So now we have 2 options, either to go to the break and come back again, or continue. And we have Dr. Rehab. She didn't present her presentation, which is supposed to be in the morning session. If she's available, she can pop in. We'll be happy to continue if you are happy. Is Dr. Rehab here?
If she's not here, give them at least 10 minutes break.
Yes.
Okay, and then we can try we will try to contact them to be available and come after 10 to 15 minutes break to continue.
Okay, agree.
Thank you, Dr. Fatma.
Thank you very much, and thank you for all the audience and all the presenters and all the people who share in the discussion. Thank you very much. See you after the break.
It would be how long?
I think we changed the schedule. So do you want me to change it? I don't know what is the time now in Sudan time. I will
11.
change
I think 1:20.
1:20. So do you want 20 minutes?
No, I think
40?
1 o'clock, 20 minutes after 1 o'clock. Now in Sudan.
Okay, so let me just to change it. It is 1:20, 21. To how long? 1:40? Is that right?
I think is enough. Do you
Okay.
agree?
Yes, I think yes. We don't want to.
Okay. Okay.
Thank you very
Okay.
much.
Okay.
See you 1:40, please. Don't be long way back. Thank you.
دكتورة ولاء.
السلام عليكم. محتاجة حاجة؟ أنا سارة.
أيوة يا دكتورة سارة، عاوزة أجرب أعمل شير للفايل.
طيب دقيقة.
هي دي ممكن توقف الريكوردينج لو عايزين.
نوقف الريكوردينج.
الريكورد ما واقف.
السلام عليكم.
وعليكم السلام.
كيفكم؟ إن شاء الله بخير.
أهلا مجدين، كيف حالك؟
الحمد لله.
يا هلا بكم.
أخباركم إن شاء الله كويسين؟
كويسين الحمد لله، الله يعافيك.
طبعا أمل سبقتني على نفس الفكرة. الريكورد وقف ولا شغال؟
يا دوب وقف.
دقيقة.
ولا لسه ما
لا
عارفة.
شكله، لا شكله
لسه
شغال. بس
شغال،
ادوني دقيقة.
لسه شغال هاي.
ادوني دقيقة أقفله، لحظة شوية.
Okay. Welcome back, everyone. Our next speaker is Dr. Magdalene Ahmed Mustafa Qurashi, MD from SMSB, Head of the Radiology Department at Al-Tamayuz Emergency Hospital, and a Senior Specialist at Khartoum Breast Care Center and Royal Care International Hospital. She will present imaging the targeted breast, post-surgical and post-radiotherapy changes. Dr. Qurashi, please go ahead. The mic is yours.
Thank you. Thank you, everybody. I'm so glad today to be here with you في السياحة الظريفة دي إن شاء الله. إن شاء الله today we are going to speak about imaging of treated breast post-surgical and post-radiotherapy changes. As we know, breast cancer treatment involves surgery, radiation therapy, sometimes chemotherapy, and this therapy alters normal breast architecture, making subsequent imaging challenges. So a radiologist must be familiar to unexpected post-treatment changes to avoid unnecessary biopsies and to detect a recurrent accurately and earlier. So we use mammography and digital breast tomosynthesis. This is a modality, radiological modality. We use it for evaluating post-treatment breast. And the mammography is the primary and most common surveillance tool. Digital breast tomosynthesis help to reduce the tissue overlap, improve sensitivity, and for subtle changes to be easy to be detected. Sorry, I want to.
Yes.
A useful adjustment to mammography, ultrasound, especially for evaluating palpable masses, area of architecture distortion, or in a patient with dense breast. So mammography, ultrasound, and third modalities is MRI, which is most sensitive modality, often resolved for high-risk patient, like BRCA carrier or when other imaging inconclusive. It is not typically performed immediately post-treatment due to inflammatory enhancement. So we use these three modalities to evaluate the post-treatment. The post-treatment changes divided into two groups. Early phase اللي هي من 0 to 6 months, and late phase from 6 months and up to many years. So today, inshallah, we are going to take a brief overview about these changes. Early phases اللي هي من 0 to 6 months. First one هي الهيماتوما والسيروما. في الماموجرافي عادة بيكون لنا round or oval circumscribed density. بالالتراساوند بنلقاها the fluid collection that may contain internal echoes اللي هو بتجينا from product of blood. الابيرنس typically بتكون لنا decrease in size over time. once انه انا لقيت increase في السايز بتاعها في subsequent images دي بتبقى لنا suspicious finding. So as we see here this breast mammogram we show a large oval shape circumscribed dense lesion measure 4.6 centimeter. In subsequent images this lesion decrease in size by significant reduction from 4.9 to 2.7. So this just a simple seroma. By ultrasound here, as we see here, this patient premenopause woman underwent left modified radical mastectomy for invasive ductal carcinoma. Subsequent developed breast masses في الاريا of surgery. بالultrasound found to be hypoechoic to some extent irregular, but with the surrounding breast parenchyma is totally normal. No feature of invasion, no feature of suspicious feature. So it is confirmed to be seroma. Another patient having lump at the side of operation. By ultrasound found to be circumscribed, oval-shaped, smooth outlines, echo-free, and confirmed to be seroma. Another patient here, sorry, this 64-year-old woman had a history of breast cancer, underwent left modified radical mastectomy and adjuvant hormonal therapy, developed also TEC radiation, present by by pain and hematoma persistent, as we see here. In T2 fat SAD, there is hyper intense heterogeneous fluid collection. Here في unenhanced fat SAD T1 look circumscribed, oval shape with high signal intensity suggestive of hematoma. Both contrast show no evidence of enhancement or internal enhancement, and في subtraction it's almost disappears. So this confirmed to be hematoma. Another changes post surgery or post therapeutic هي السكن and trabecular thickening. This caused by edema or inflammation related to surgery. في الابيرنس بنلقاها في increase in density في الماموجرافي. Gradually subsequently بيحصل لها resolve by months or years. Another changes also related to a surgical scar, which is appear as dense area or area of artificial distortion, often continuous مع السكين interside, also decrease or disappear أو نلقى فيه change في density over time. Any changes في الفيتشر دي is a suspect of malignancy. As we see here, this is a patient underwent lumpectomy. This 2008 there is increased skin thickening. 2 years later it is almost decreased thickening. Here 1 year later almost the skin almost return to the normal appearance. Here the same patient. لو لاحظنا هنا في يعني في massive skin thickening. هنا comparison بين two images من اللي في reduction, and the last images في 2013 is almost return to the normal. So this is a benign change related to the therapeutic change. Another patient here, as we see, this area of high density representing scar area. As we see here, it is attached to the interside or over the skin. It is measured 2.6 centimeter في 2008. 2010 it is reduced in density and in size. So these are benign changes related to a therapeutic. نجي نتكلم إن شاء الله عن شنو عن البوست سيرجيكال and post radiotherapy changes الليت فيس اللي هي بتجينا post 6 months. أول حاجة فيها هي شنو؟ هي السكار تشو and artificial distortion. في الماموجرافي بنلقى فيه fixed area of distortion which should be remain stable أو يحصل لها shrunken over time. يعني once إنه هي stable في ال subsequent images or هي حصل shrunken it is good, it is benign changes. إذا لقينا في أي alter في الحاجة دي increase in size ولا حصل لها progression this mean في suspicious بتاع recurrent. Also true recurrent often بيكون لنا في enlargement في الماس دي أو يحصل لنا more distortion. So if I found the changes stable or حصل فيه shrunken by time this is good. If حصل فيه enlargement أو حصل فيه more distortion this alarming بالنسبة للراديولوجيست. As we see here, this 73-year-old woman had a history of left breast cancer after lumpectomy and radiation 2 years prior. The patient present with the new pain في ال scar area. لما اتعملت لها المموجرام ال MLO بنلقى إنه هنا عندي area of distortion وفيها density with containing calcification related للarea بتاعت السكار. But as we see here, this area containing fat unlikely to be a malignant, so it is related to benign changes post-surgery. By ultrasound, as we see here, this increases skin thickening في subcutaneous edema في fluid في interstitium and increase the vascularity. All this is benign changes. Just your role or my role as a radiologist to follow these changes in the subsequent images and so that follow up or comparison between a recent and previous images is the most important في البيشنت post therapeutic to detect the early sign بتاعت المalignancy. Another patient here also بالmammography we see skin thickening demonstrated by ultrasound. There is echogenic fat with increase the skin thickening here. This confined to be a benign post therapeutic changes. التشينجز sometimes ما بيكون لنا هو بس على السبكوتينيوس والسكين. Sometimes we see here this is a pleural line. This is a pleural line in normal patient and this pleural line post radiotherapy. As we see here there is a thin regular في indulation لو لاحظنا هنا. This related لشنو؟ للchanges البوست radiation. So when we do ultrasound حتى even لو ما لقينا في changes في السكين وفي السبكوتينيوس في الغالب احنا بنلقى شنو changes deeper يعني. Yeah, another patient with radiation therapy as we see here في reverberation artifact. This is related للpleural line اللي هي changed by radiotherapy. برضو في another changes بنلقاها related للسكار. Sometimes the patient develop colloid and when we see here this tubular density, fin density, I can differentiate between إنها هي inside the breast or from the skin by شنو؟ by this loosened line here represent this is just skin lesion or skin pathology, not intra-breast definite pathology. The third one is fat necrosis. هو ده حاجة changes صراحة لأن الفات necrosis بيجينا من benign feature ل even sometimes بيقول لك clinical malignancy. So we should train our eyes to detect fat necrosis. الكوز عادة بيكون لنا result from damage fat cells from surgery أو radiation. في الماموجرافي كان appear as speculated mass mimicking الكانسر أو ممكن يكون لنا simple oil cyst اللي هو بيكون loosened mass أو يجينا في شكل بتاع dystrophic calcification. بالMRI عادة lesions containing fat as we know هي generally benign lesion. Sometimes بنلقى فيها peripheral enhancement and this typically يعني no worrisome. هي by ultrasound عندي well defined hyperechoic breast mass في eccentric cystic lesion mass measure 4 by 3 centimeter here this lesion immediately under the scar. So this is a BIRAD 2 as هي عبارة عن شنو؟ fat necrosis proven by biopsy. هي another changes عندي لو لاحظنا في breast edema في increased fat echogenicity عندي 2 hypoechoic lesion vertical oriented في irregular outlines، لكن لو لاحظنا ما عندي acoustic shadowy، يعني هي مايلة إنها تكون لنا شنو عاملة لنا acoustic enhancement، يعني دي شوية relieving أنت لما بتكوني بتعملي في الإسكان. and this patient underwent biopsy and proved to be fat necrosis. عشان كده قلنا الفات نيكروزيس يعني عنده وايد رينج، فالواحد يكون cautious، يكون يعني alert وهو examine the post treatment breast. As we mentioned before, fat necrosis can be present as dystrophic classification. Here, as we see, arc-like classification or curvilinear classification representing fat necrosis. Also can be appear as dystrophic calcification. Often ده بيكون large وبيكون coarse وفيه irregular in shape، وtypically dystrophic calcification represent appear later on اللي هو 2 to 3 years post treatment. اللوكيشن عادة بيكون لنا في الoperative side. As we see here, this is the MRI of post treated breast. في الoperative bed عندنا large macro calcifications representing scar tissue. برضو من الحاجات اللي احنا مفروض ننتبه لها في اثناء السكانينج اللي هم البيشن اللي بيكونوا بيحصل لهم modified radical mastectomy with يعني reconstruction زي like this patient here as we see here. This line here, this line representing شنو؟ representing ال density between reconstructed اللي هي دي patient عندها modified radical mastectomy with transverse rectus abdominal muscle reconstruction. فدي اللاين ده هو represent a line between the breast tissue. This line represent a line between the breast tissue والمصل اللي احنا عاملين بها reconstruction. الاريا دي يعني احنا المفروض ننتبه لها جدا. ليه؟ لأن دي الاريا اللي بيحصل لنا فيها الريكرنس. ليش؟ لأنه هنا دي الريزيدوال بريست تيشو موجودة هنا عندي. سوري. الريزيدوال بريست تيشو بتكون لنا موجودة هنا، فأنا when I do scan I should be careful to examine this area. تمام؟ نمشي للsuspicious finding اللي هو الريد فلاجز. وين بلقاها أو 200 أنا أعمل ريد فلاجينج في الإسكان؟
أنا أكلتها في محاضرة أقفلوا لي الباب ده.
enlarged masses لما ألقى في new density حصل فيها enlargement أو لقيت enlarged mass at lumpectomy site، أو لقيت في elsewhere لقينا newly developed mass دي highly suspicious for recurrence. Also إذا كان حصل لنا develop of asymmetry، يعني أنا ما كان البريست تيشو ما فيه حاجة، وفي ال subsequent examination لقيت فيه developed asymmetry، برضو دي المفروض to raise my red flag to be more evaluated. As we see here, this patient had a post breast conserving therapy في السكار. ده السكار تيشو بتاعنا. لقينا إنه عندي هنا لو لاحظنا في شوية density في subsequent investigations this density become more obvious than previous, and 1 year later it become obvious and with surrounding distortion, so this is suggestive of recurrence. Another patient here, this post treatment breast with distortion وفي عندنا density هنا. في subsequent examination لقينا إنه density هنا كانت just asymmetry، هنا become almost become mass like asymmetry وفيها become denser. So this patient like this should be go to more investigation about this area of newly developed density. Another patient here, as we see here, sorry, this asymmetry في subsequently لو لاحظنا هنا كانت obvious، هنا شوية slightly reduction في ال changes، لكن لو لاحظنا حصل لنا develop of شنو of overlying skin thickening. بالسبسيكونت examination لقينا إنها almost develop mass في الاريا بتاعت السكار and this is alarming. this is معناها suggestive of recurrent. Another patient here. This is the scar area. As we see here, it is clear. Just the post-surgical and posterior therapeutic changes في subsequent examination nothing. لكن في الريسنت أو last one لو لاحظنا الدنسيتي بتاعت ال overall breast increase, الإديمة increase, ال overlying skin thickening increase, and there is a new developed lesion here. As لو لاحظنا هنا في نيو فنت ديفلوب اوف اسيمتري هي في البريفس ما كانت فيه لكنها ما كانت alarming. في السبسيكونت اكزامينيشن لقيناها almost mass like. معناها دي شنو؟ دي recurrent of lesion في different quadrant يعني not the same operative bed. وبالتالي المسج اللي بناخدها من الكيس دي انه احنا when we evaluate the post-therapeutic breast we should be alert focusing not only on the scar area but كل البريست احنا مفروض نكون مركزين فيهم. another case here زي ما شايفين this here before الاوبريشن. هنا اتعملت لها اللومبوكتومي لقينا فيها سكار تشو. في لو لاحظنا الدنسيتي كانت نورمال برينكيمال دنسيتي. subsequent examination الاوبريتيف بيد is clear ما فيه غير التشينجز لكن الدنسيتي الموجودة هنا develop another mass with overlying skin thickening. لو لاحظنا في البريفس ما كانت فيه skin thickening. generalized edema present. هنا البريست كان almost free. فدي شنو؟ دي definitely newly developed breast cancer. من الحاجات اللي برضو ممكن ألقاها وأنا مفروض أكون منتبهة لها هي شنو؟ السسبشس مايكرو كالسيفيكيشن. فأنت دايما لما زي ما قلنا إحنا بنلقى فيه ديستروفيك كالسيفيكيشن لكن ده ما يخلينا يعني ما يشغلنا من إنه نركز في الديتيلز عشان sometimes بنلقى فيه فاين أو لينر أو برانشين مايكرو كالسيفيكيشن قاعدة لنا مع الديستروفيك كالسيفيكيشن الجاية من بوست التريتمنت. فاللوكيشن بتاعها ممكن نلقاها في الأوبراتيف بيد ممكن نلقاها everywhere. فبالتالي زي ما أنا قلت قبل إنه إحنا لما نيجي to evaluate the post treatment breast we should be alert and review every centimeter في breast. So as we see here this patient دي primary investigation بال magnification we see here this suspicious calcification. The patient underwent surgery and this post treatment changes. لكن in spite of these changes there is faint هنا faint suspicious calcification. في الماجنيفيكيشن لو لاحظنا عندي عبارة عن clusters بتاعت suspicious calcification. بالماموجرافي لقينا بالام ار اي لقينا هنا فيها شنو؟ في enhancement. لما اتأخذت بايوبسي طلعت هنا هدية DCIS. عشان كده دايما في المانجمنت بتاع DCIS breast لما نكون عايزين نعمل conservative surgery we should evaluate the rest of the breast carefully والrest of the specimen post surgery برضو carefully عشان ما يكون عندي residual بتاعت calcification تعمل لنا recurrent earlier. هي another patient زي ما ملاحظين عندي dystrophic calcification هي لكن عندي في الباك جراوند في suspicious calcification. فيها لو لاحظنا عندي suspicious micro calcification. بالام ار اي لو لاحظنا عندي هنا الاريا بتاعت السيروما لكن هنا عندي شنو؟ عندي enhancement cell lesion this is recurrent. also من alarming feature لو لقيت عندي increase الثيكنينج. لو السكين ثيكنينج الايديال اذا كانت هي normal changes المفروض بالسبسيكونت images القاها حصل لها regression او stable على الاقل. لكن لو لقينا انه الانيشال ايديما ماشيه لنا بروجريسيف وزادت السكين ثيكنينج this is alarming and should go for further examination. As we see here, this patient في 2007 بس changes increase شوية. لكن لو ما جينا ل 2009 لقينا إنه الإديمة generalized بقت بعد ما كانت localized على السكين بقى السكين thickening الثيك trabeculation الدنسيتي ذاتها increase. This is alarming and should go for for further evaluation في this patient. The same patient هنا sorry same patient هنا اتعملت لها MRI، لقينا إنه عندي فوكس هنا بتاعت في الديفيوجن حاصل فيها يعني suspicious. بالالتراساوند تارجت الالتراساوند السيم اريا لقينا إنه عندي شنو، عندي suspicious lesion here. Biopsy taken and histopathology revealed angiosarcoma. Another patient here, this post-treatment breast. في subsequent evaluation لقينا في increased trabeculation, increased skin thickening, and this is suspicious, and this patient should be evaluated further. لما اتعملت الالتراساوند لقينا انه عندي شنو، عندي irregular hypoechoic areas وفيها vascularity. ف this revealed to be post histopathology in invasive ductal carcinoma. This is a recurrent case. Also evaluation post surgery الماستوكتومي side أو ماستوكتومي bed should be evaluated. يعني عادة في الماموجرافي في الماستوكتومي أحيانا بيقدروا يعني التكنيشن بيقدروا يعملوا لك الأكزيلا في الMLO view. لكن أنت should be يعني train your eyes to evaluate the operative bed, and sometimes like this patient here, this operative bed reveal two hypoechoic lesions. here لو لاحظنا عندي هي small لكن ال posterior acoustic shadowing is extensive وهي irregular و hypoechoic, and this is proven to be to focus of recurrent. من الحاجات اللي برضو احنا بنحتاج نشوفها في الفولو اب ايمجز اللي هي شنو البريست ريكونستراكشن، اللي هي بنشوف الكومن سايد بتاعت الريكورنس الكومن سايد بتاعت الريكورنت في الريكونستراكتد بريست زي ما قلنا قبل هي في حته الجنكشن بين الفلاب والناتيف بريست تشو. فالمفروض الجنكشن ده أنا to evaluate well عشان ما to miss any lesion. يعني طبعا زي ما احنا عارفين early detection good prognosis. also بالimages مفروض to evaluate الإمبلانت في حالة السيليكون إمبلانت وكده، وبشوف إذا كان في local recurrent حولها أو إذا كان حصل فيه الانتجريتي بتاعته ذاته حصل فيها problem. الإمبلانت better to be evaluated بالMRI طبعا. also البيشن لو كانت عاملة augmentation بالفات injection وكده برضو بشوف الchanges اللي بيكون due to injection of the fat. As we see here, this is a 61-year-old woman, 4 years after initial diagnosis of invasive ductal carcinoma, جاية بincidental finding of local recurrent في transverse rectus abdominis. لقينا إنه في الفلاب هنا posteriorly في lump. اللمبي ده لو لاحظنا حاصل ماخد enhancement بالماموجرافي، لقينا انه هاي density almost في الاوبراتيف بيد وفيه irregular outlines وحوله distortion overlying skin برضو thickened. بالالتراساوند لقينا انه عندي hypoechoic irregular speculated lesion proven to be recurrent lesions. Another patient here as we see this بالماموجرافي عندي في الأوبراتيف بيد speculated high density lesion. بالماموجرافي لقينا عندي شو enhancing الهيوج في الحتة بتاعت شنو الجنكشن between الفلاب والناتيف بريست tissue, and this proved to be recurrent invasive ductal carcinoma. As we mentioned prior إنه we use the MRI for evaluation الانتجريتي بتاعت السيليكون. لو لاحظنا هنا this is almost clear، لكن هنا عندي شنو، عندي changes في الإمبلانت ودي represent implant rupture. هنا دي patient injection of fat. لو لاحظنا عندي area بتاعت fat with dystrophic calcification, and all these changes is benign related لشنو؟ related للأugmentation by fat injection. So in conclusion, breast cancer treatment involves surgery, radiation therapy, and sometimes chemotherapy. This therapy alter normal breast architecture, making subsequent imaging challenges. So radiologists must be familiar with expected post-treatment changes to avoid unnecessary biopsies and to detect the recurrent accurately. Imaging of treated breasts require familiarity with the spectrum of changes from expect treatment effect to sign of recurrence. يعني المفروض الراديولوجيست to be familiar مع these changes. Serial images is a key to distinguishing stable benign changes from developing malignant ones. Multimodality approach using mammography, tomosynthesis, ultrasound, MRI, and guided by patient history is critical for optimal patient care. Radiologists play a vital role in accurate interpretation, ensuring timely evaluation of suspicious finding. So, take-home messages to conclude: mammographic ultrasound and MRI appearance of the breast is altered in the post-operative and post-radiotherapy setting, and breast radiologists should be considered of feature suggestive of recurrent disease to identify it early. It is just as essential to be aware of normal evaluation of birth therapy changes to avoid unnecessary further workup and stress to patient and to you and to your unit. And thank you.
Amazing
Thank you.
presentation as usual.
Thank you.
Thank you very much, Magdalene. Really informative and to the point.
Thank
Just
you.
one point, just to emphasize on what Magdalene said. Without previous imaging, we cannot exclude recurrence.
Yes, exactly.
We cannot exactly without compare with the previous similar or correlate with the previous other modality, breast imaging, we cannot exclude recurrence in post-operative, especially post-radiation changes. We cannot. Another point just to emphasize on. Dystrophic calcification is straightforward, reassuring, but there is certain points we have to concentrate and to consider it. Early on, dystrophic calcification starts as fine calcifications, and it can simulate suspicious of the recurrence. Okay, this is one point. The other point, when it becomes clumpy, large dystrophic calcification, it can be like a mass and it can be palpable. And we should not look at it like this and say this is large calcification, so it is benign and that is it. No, we have also this correlated with the previous. For any displacement or any early fragmentation. Okay, this if we see this clump of mass or mass of calcification start to displace from its place, okay, exactly, it might represent underlying lesion pushing, giving a mass effect on this calcification. This is, I have experience of one case before of dystrophic calcification, recurrence displacing dystrophic calcification, or it can result in fragmentation. Try to compare it. It might not fragment it as a whole. It might start to be fragmented from periphery or from central. So we have to be cautious even while compare this mass of calcification. Thank you very much. Again, thank you, Magdalene. Really informative lecture.
Thank you دكتورة حباب. يعني بجد البوينت اوف فيو اللي انت ركزت عليها it is so important. Thank you so much.
You are always welcome.
Thank you very much for the nice discussion and excellent presentation. So you have Hiba Mu'tasim. She will be the moderator for the next sessions. Over to you, Hiba.
Thank you, Dr. Majduleen, and I'm Hiba Mu'tasim, and it's my pleasure to be with you in this informative symposium. Our next speaker is Dr. Medina Ali Muhammad Mustafa, MBBS and MD holder from Sudan Medical Specialization Board, consultant radiologist and chair of Sudan Medical Specialization Radiology Board, president of SSBIWH and head of radiology unit at Kendi Oncology Hospital. Her topic for today is male breast image. Mic is yours, Dr. Medina.
Are
ما
you
شاء
there, Dr.
الله.
Medina?
السلام عليكم، عبد الله جابر معكم. ما شاء الله ما شاء الله، متابعكم حلوين جدا جدا. Very good.
شكرا يا بروف،
Continue.
شكرا شكرا على الدعم.
So nice session, so nice talk. I see my girls خلاص بقوا في القمة يعني ما شاء الله. صحورها.
الله يكرمك يا بروف، دائما داعمنا. الله يكرمك يا رب وأدامك علينا عز للأشعة إن شاء الله.
إن شاء الله
دكتور هبة
دايما
كيف
معلين
حالك؟
راسك.
دكتورة هبة شايفك طلعت خلاص بقيتي ما شاء الله عليك. والبنات
الله
هنا
تبارك.
سحورة ما شاء الله يعني بقت خطيرة. ربنا يوديكم أعلى وأعلى إن شاء الله. إحنا بس we support you يعني إنكم تمشوا لقدام إن شاء الله. ما قصرت والله. This is a very nice يعني well documented session وبيدل إنكم يعني السيلف تريننج بتاعكم ما شاء الله عليه. continue. الله معاكم.
الله يكرمك.
شكرا يا بروف، ربنا يكرمك إن شاء الله.
مدينة موجودة ولا نمشي اللي بعدها؟ مدينة لأنها في
السلام
السودان
عليكم.
كأنها شغالة. وعليكم السلام.
أنا دكتورة رحاب. If she's not ready, I'm ready to present.
أيوة على طول.
You can
لحد
ask
ما
her first
تجي،
and then
لأنها حتى ما ردت في
it's okay.
الواتساب فأنا بكون متابعة معاها. شكرا يا دكتورة رحاب، الله يديك العافية.
أقول لك دكتورة هبة تابعي مع مدينة في البرة، لأنه أول ما تقدر تلقى لها حبة نت حتخش، لأنه المشكلة في السودان النت يعني.
أيوة هي متواصلة معي
see
في الواتساب.
فعلا.
just
أيوة.
continue. وأنا النت دي حتى لو جاء أقطع الريكشر بتاعت رحاب
أنا في السودان يا
رحاب
بص.
ذات اسمع رحاب ذاتها
رحاب ذاتها في السودان.
لكن رحاب قاعدة
أنا
في
قاعدة في
العاصمة.
زاوية.
رحاب ازيك يا
لا
حوبة؟
والله قاعدة في زاوية. كيفك يا
ما
بروف؟
قاعدة في...
مشتاقين. كيفك؟ تسلم. بسم الله.
So we have Dr. Rehab. Dr. Rehab Osman Abdullah Ali. She is holder of MBBS from Kassala University and MD from Sudan Medical Specialization Board, serving at military and police hospitals. She will discuss breast density assessment and reporting standards. Over to you, Dr. Rehab. Mic is yours.
Okay. It's there.
It seems unfortunately the communication from Sudan would be very difficult. But if you let them just move the slides بتاعتهم at least يعني they share the slides with the meeting يكون أفضل، لأنه possibly ما
لكن ده أعرف it's not sharing. I don't know what's going on.
ما في مشكلة. انت لو الصوت بقى زي ما قال البروف، لو بتقدري تتكلمي، لأنه تخيلي النت ممكن يسعفك تتكلمي ونحن ممكن نمشي لك بالسلايدز. لو عايزة شيري لنا في الواتساب بنشيرها ليكي هنا.
It is
مدينة
better,
سامعة؟
Rahab. It is better to send your presentation Wala or Sarah to make it from here, and you can just present.
تمام، حارسلك هسه.
أنا حرسلها لك يا هبة تشيريها، هبة معتصم.
تمام.
طيب أرسلك يا دكتورة رباب ترسلها اليوم؟
رسليها لي في، أنا متواصلة معاك في الواتساب يا رحاب. رسليها لي
رسلي
في
هسه.
الجروب.
ما لاقياكي. You send it to
Okay,
me?
send to me, Rehab. Send to me. I will forward it for them.
Tamam.
You have sent it?
Geldik ya.
Not yet. I did not receive it.
Net. كده
شيرتي يا دكتور؟
Okay.
Not yet received.
مدينة برضو موجودة يا جماعة لو
excuse me يعني النظر يعني وايد ثاني
طيب
let
دقيقة. تمام
whoever is
تدخل دكتورة
ready
مدينة معناه.
let whoever is ready to continue the meeting
دكتورة مدينة
while you were preparing the
مدينة
slides
موجودة
of
خلاص
Medina and
نشير
Rehab.
لها شيري لها
تمام
شيري يا مدينة.
حلو تمام
يعني دي خلوها في بالكم
ظابط.
يعني لو في اي difficulty the next speaker وبعدين انتوا المنظمين تشوفوا الطريقة تجيبوا السبيكر.
خلاص
تمام
يلا
it's
هبة
okay.
معتصم شيري
تمام
مدينة.
تمام أنا أرسل. شكرا.
شكرا يا رحاب، بنرجع لك بعد مدينة طوال إن شاء الله. هبة معتصم موجودة ولا شير أنا؟
موجودة.
لا شير
أيوة
انت ولا
دقيقة.
يلا شيري البريزنت. اوكي
السلام عليكم ورحمة الله. I'm glad to see you again in the 4th annual symposium in Pink October. I'm Dr. Medina. I'm going to present for you male breast imaging in this gathering of the symposium. A greeting to all of you. Next. I'm going to talk about male breast. Common lesions are gynecomastia, male breast cancer, and beyond. Next. Okay, gynecomastia versus CA breast. As you know, gynecomastia is simultaneous proliferation of ducts and stroma without encapsulation. So we see proliferation of ducts and stroma embedded within fat globules. So it must blend into the surrounding fat tissue. Also bear in mind, no proliferation of the lobules, like in women. So rarely we see those lesions that originating from the lobules, like lactating adenomas, fibroadenomas, phyllodes tumor, and also invasive lobular carcinoma. These are extremely rare in male. Next. Okay, these are two MLO views of male breast. The one on your left is retroareolar density embedded within the fat globules without encapsulation. So this is the gynecomastia. And the one on your right is breast cancer which is encapsulated dense mass seen in the anterior aspect of the male breast. Next. Okay, there are many types of normal male breast. For example, in the mammogram, we can see normal skin and nipple with a small amount of connective tissues behind the nipple, just a small linear shadows of connective tissue at the retroareolar space, where sometimes we see more connective tissue, as in the next slide, please. The mammogram on your left, we can see small breast tissue with small connective tissues seen as linear densities in the mammogram, where in the MLO view of the male breast on your right,
Unfortunately شكلنا فقدنا الدكتورة مدينة.
Give her few minutes.
Okay.
She might rejoin. If you have any questions from the previous presentation, you can ask while waiting for Dr. Medina to rejoin.
There is a lot today, to be honest. A lot of things you can discuss.
Yeah. Any questions for Dr. Fatma, for Dr. Hiba, for Dr. SSBIWH, for Dr. Magdalene? From Hiba to Magdalene, who presented already. If you have any question, you can ask while waiting for Dr. Medina.
Excuse me, I'm in Sudan,
Yeah.
and this is the normal physiology.
Expected. You are welcome.
Excuse me again. Can you hear me?
Yes, we are hearing you.
Okay, I'm in Sudan, and this is a normal physiology of our internet connection. Excuse me
No
again.
problem. We are happy to have you.
Okay, thank you. Wala. Okay, we talk about these two slides or two mammograms of normal male breast. Okay. Also, we can see a normal breast of male with extra fat, normal amount or a small amount of fibrous connective tissue, but basically most of the breast is composed of fat. We can see it in the next slide, please. Yeah, this is a mammogram of a male breast with excessive breast fat. And we can see a little amount of glandular or connective tissue seen as linear dense shadows in the anterior breast. This is the CT, and this is the MLO with extensive fat. Okay. This is also a normal breast mammogram. This is a normal looking at the MRI and CT with a small little amount of fat with small nipple, small connective tissue. Okay, next slide. Okay. Gynecomastia is the most common abnormality in the presentation of male with a breast problem. Clinically, it presents with a soft, mobile, tender subareolar mass. Every word in this definition or description is important. So it must be soft, not hard. It must be mobile, not fixed. In the acute phase, it is tender, and it must be central in the subareolar region. This is the mammogram with okay, I'm back.
You're welcome.
Okay, thank you. As we said, it must be soft, mobile, tender subareolar mass. In the acute phase, it must be tender. And this is MLO view of a male breast with gynecomastia. Next slide. As we said, it is a proliferation of ducts and stroma without proliferation of lobules. Next slide. There are three imaging patterns of gynecomastia. First is the nodular glandular in the acute florid phase, and dendritic in the chronic fibrotic phase, and diffuse glandular in special cases, as we are going to see. This is a nodular glandular pattern. Notice how it blends into the surrounding fat. This is the nipple is with a mark, and this is the diffuse large retroareolar density embedded within the fat with multiple or with a large opacity or density seen in the male breast. This is the nodular glandular pattern in the acute florid phase. This is the ultrasound of gynecomastia. You can see it at the finger-like projections within the fat, not the posterior projection. The finger-like projections, how it melts within the or embedded within the breast fat. This is the typical appearance of the gynecomastia. Next slide. The dendritic pattern is seen in the fibrotic or late phase. We can see dilated ducts, moderate epithelial proliferation, and fibrosis. So most of the dendritic phase is seen as bands or extensions seen within the fat of the breast. Next, this is the mammogram of the dendritic phase. As you see, this is subareolar density with prominent extensions into the fat, posterior extensions. the density is smaller than the nodular pattern. So this is chronic phase, and the first one is the acute florid phase. Next. This is the mammogram. On two images on the left are the CC and MLO views of male breast. We can see the fibrosis with linear extensions into the fat extending posteriorly, while in the ultrasound on your right, you can see the extensions are seen and like the fibrotic band seen going posteriorly embedded in the breast fat. This is the dendritic chronic phase of gynecomastia. Next slide, please. This is the diffuse glandular pattern. This is the third type of gynecomastia, special type seen in high estrogen levels, which is seen in some cases like hormonal therapy of the prostate. This is the male breast with bilateral MLO views, show dense diffuse glandular density in both breasts, representing diffuse glandular pattern of gynecomastia in patients with CA prostate. Next slide. Also, pseudogynecomastia is a special category in patients seen with excessive fat deposition in the male breast. This is the normal, well-developed breast of a male with no palpable mass clinically, but there is excessive fat deposition. We can see it in a normal variant, normal patient with normal body weight, or in obesity, or in cases with neurofibromatosis, accumulation of fat, excessive fat in the male breast. This is called pseudogynecomastia. Also, it is a normal seen in normal variant. Okay. Let's talk about CA breast in male. As you know, it is a common disease. CA breast can involve male or female, but it is less seen in 1% of all breast cancer. In USA, there are about 1,700 new cases each year of male CA breast. The higher incidence seen in China and Africa due to chronic liver diseases, due to parasitic infections, and secondary hyperestrogenism. These cancers present as unilateral, painless subareolar mass. This subareolar location is just like gynecomastia, but usually it is eccentric rather than central subareolar. Usually they present late because after the mass increase in size, they may come with fungating mass, or just eccentric palpable mass, or bloody nipple discharge even. Next slide, please. Types of malignancy in male breast. We can see ductal carcinoma with different special types. Invasive ductal carcinoma is usually the most common type with about 94% of cases. Papillary colloid are less, and the least is lobular, because we talk about the no proliferation of lobuli in the male breast. Other types are liposarcoma, lymphocytic lymphoma, or lymphoblastic lymphoma, or metastasis in the male breast. This is a comparison between gynecomastia and carcinoma. You can see a glance, a great similarity between the two. There are multiple shared characteristics between them. Both are involved above 60 age or at the 60s. They may both may be soft might be palpable or mobile. Most of the gynecomastia are tender in the acute phase, but the carcinoma is painless. They might be subareolar, but the gynecomastia is central, and the CA breast might be excentric or usually is excentric. Gynecomastia mostly are bilateral, wherein the carcinoma usually is unilateral. The gynecomastia is nodular or fibrotic. The carcinoma is usually the mass large or small. The gynecomastia seen as fan-shaped of density beyond the nipple and the mammogram, while the carcinoma seen as lobulated, encapsulated border mass. In the fibrotic phase of gynecomastia, we can see subareolar density with extension into the fat, and the carcinoma, we can see a projection or speculation. So great effort is should be made to differentiate between the two in the early stage, but commonly male present late with invasive ductal carcinoma because no early detection, no screening for male breast, so they didn't come early in the DCIS phase to see the mass seen within the ducts. Okay, next slide. We have to differentiate between cancer gynecomastia. Strange enough, if you can see these two lesions in the female breast, you can show that the left side is with speculation is a suspicious mass, but in the male breast, this is the normal gynecomastia with projections or with embedded within the fat lobules. And in the right, this is the breast in a male breast. This is a cancer. Just some slightly encapsulated mass. Okay, next slide. This slide or this photo taken yesterday from my home ground. In spite of our conflict in Sudan, our war, we have some plans take care of them and look after them and take some photos with them. Okay, next slide. Today we have, or every Saturday, we have October free press clinics shared with the surgery, histopathology, oncology, and radiology. We have a very crowded clinic today, ongoing activity. And now I escaped from them in a separate room in order to finish with you and meet you with the male breast imaging. These are the posters made by the small doctors in Al-Maknimir Hospital in Shendi in Sudan. Next slide, please. This is another poster made by them, naming some of the helping doctors with us from surgery, histopathology, oncology, and ultrasound. Okay, we have a very crowded clinic today, but I'm happy to meet you and hear of you and see you also. Thank you.
We are more happy than you, Medina, that you share with us this October, and we can see you. We can make sure you are in good health. And
thank you.
You are still coping. Thank you very much. Very informative and precise and to the point. Thank you very much.
Thank you.
Yes,
thank you. Thank you.
Thank you very much, Medina. We are happy to see you. Thank you very much.
So do I. I'm very happy to see you all in this beautiful and unique gathering. Thank you for your help.
We are happy for the great work we are doing in these circumstances, and it's all jaza from Allah, inshallah, al-Jannah, al-Firdaus al-A'la.
جمعا يا رب
Allah keep you
العالمين.
safe.
يعطيكم العافية. إن
Happy
شاء
to hear
الله
from
بإذن
you.
الله.
Thank you very
Yes,
much.
thanks for the details. Thank you.
Okay, one point just to be added regarding the gynecomastia. Sometimes it is challenging, especially the nodular gynecomastia, because it might be because it is more similar to a mass. Okay.
Yes.
That is why it makes some challenges. It makes some challenges to say this is just a mass or
Yes.
a nodular gynecomastia. This is one issue. The other issue, we might have acute on top of chronic gynecomastia. For those who have long-standing cause of gynecomastia, like liver disease or receiving long-standing some drugs. There are some treatments causing the gynecomastia, and we
Yes.
might find the dendritic. On top of dendritic, we might have acute florid. So it also
Yes.
might make us to think about developing mass on top of gynecomastia. And this, when acute gynecomastia present, it might be associated with hyperemia as well as with edema, which is make it also more challenging. Okay, and sometimes
Yes.
you might need to proceed for MRI for further characterization and even for biopsy in some of the cases. That is what I want just to add from my experience. Thank you very much, Medina, again, for this
Thank
very
you.
precise and informative lecture.
Okay,
Thank you
thank
very
you
much,
for
Medina, for this
Thank you.
comprehensive presentation. I would like just to make a highlight for some recent updates and observations in breast pathology among transgender male and female patients in Europe and in our current practice. So across Europe, there are a growing body of research addressing body pathology in both cisgender and transgender individuals, reflecting the need of inclusive imaging and diagnostic approaches. So we have a lot of increasingly breast cancer in males and different even normal breast mammograms for them. So because of in transgender women, male to female changing, there is long-term estrogen therapy, which lead, as you know, which will lead to development of glandular breast tissue similar to female. So this make screening and assessment protocol comparable to those of cisgender women. So we have reported cases of fibroadenomas, gynecomastia-like changes in women and in men, and rarely increase the incidence of invasive cancer similar to HRT patients. So there is emerging discussion about
Interesting, really interesting. Well, thank you.
Yeah, we have
Thank you
a
for
lot of
adding this information. Yeah,
and they
because
have
they are
even screening programs.
they are receiving hormones, and the hormones
Yes.
can change. Do
Yes.
they receive progesterone or only estrogen?
Estrogen,
because
progesterone, they have a lot
because as we know, estrogen working at the level of the duct, and the rudimentary breast is mainly form of ductal system. Okay, and when any change in estrogen level, it will proliferate the ductal system with very minimal scattered lobule. So as Medina mentioned, that is why they don't have any lesions that arising from lobular terminal duct lobular unit, with exception, not complete, but exceptionally rare, because are really scattered for them. But if they do receive is progesterone, they might develop as well terminal duct lobular unit, because this hormone is responsible for the development, as we have seen at the pubertal girl. Okay, the presence of estrogen working at the level of duct and stroma and the progesterone work at the level of terminal duct lobular unit. And in the lactating woman, pregnancy and lactation, they have a lot of progesterone that work and increase the size as well as number of terminal duct lobular unit. That is why when numerous terminal duct lobular unit, which appear as isocoic oval structures within the fibrotic uh, hyperechoic parenchyma, start to enlarge, become numerous in number and enlarging in size. So abutting each other, the parenchyma will turn from hyperechoic to just isocoic to the fat. And sometimes even you might see the whole breast like a fat, but it is a glandular or what is we call it physiological adenosis.
Yes.
See, that is why I think they might receive this also as well as estrogen, progesterone, that will increase.
Whichever hormones they are receiving, they have a system now of screening similar to, they have a protocol of screening like after 5 to 10 years. So both Europe and RCR and even I think American College of Radiology, they have they will start screening after 5 to 10 years after receiving hormones, whichever hormone are receiving. And they will start the screening similar to women after here in Europe after the age of 50. So they are considered as female breast, whichever hormone they are receiving.
Yeah, because estrogen is known to increase. I'm just explaining the point of, you have mentioned that increasing number of fibroadenomas. That is why I told you because of increasing number of fibroadenomas that might have also received progesterone as well as estrogen. But even if they receive estrogen only, it will increase the risk of breast cancer definitely.
Yes.
Thank you for this update.
Thank you.
Thank you.
Thank you for
very
the
much.
update, Wala.
Thank you. Yeah,
You're
thank you, Wala.
Thank you for the update.
You're welcome, Medina. Thank you very much.
Okay.
Dr. Latifa, do you have any comment regarding this new update in your country regarding this group? Are you with us or she might?
I don't see Dr. Latifa in the audience.
She might left. She might left. Okay.
Is Dr. Rahab available? Yes, she's here.
Yeah. I think it's not working. It's started already, but
I didn't receive the presentation.
Is it shared right now?
It is sharing, but we can't see the presentation.
It's
yes.
Yes.
Yes, we can see.
I'm trying to share the screen. It's okay right now? Can I start?
رسلي لي كده في الواتساب يا رحاب، انا بشيره من عندي وبمشي ليكي انت بس قول لي نكست. يا رحاب. شكلنا فقدنا التواصل بالشبكة.
دكتورة هبة, if you have the slides, just run the slides. Run the slides.
ما بعتت لنا.
واحد يدخل لها في الخاص خلاها تسندت.
دخلت لها في الخاص لكن شكله النت حتى يعني في الواتساب ما ايزي انها هي.
خلاص سيل لغاية ما تعمل arrangement go to next speaker.
أمل جاهزة؟
في next speaker.
أيوة
جاهزة
أمل.
أيوة.
دكتورة أمل.
خليهم
يلا.
تطوعوا.
تمام. Is Dr. Hiba around?
Yes. Our next, thank you, Dr. Medina, for informative presentation.
Thank you.
Our next presenter is Dr. Ahmed Mustafa, a radiology specialist with MD and Arab board certification, working at Wa'ad Specialized Hospital at Khartoum, and attended at King Saud Hospital, KSA. Our topic for today is role of ultrasound in management of breast cyst. Mic is yours, Dr. Amal. I will share your presentation, right?
Yes, please. Yes, please. Share
Okay.
her presentation.
Okay.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام دكتورة أمل.
وعليكم السلام ورحمة الله.
Are you able to share, Hiba?
Yeah.
Thank you.
Can I start?
Okay, Bismillah ar-Rahman ar-Rahim. Alhamdulillah, wassalatu wassalamu ala Rasulillah. I'm very pleased to be with you today in this symposium. I'm going to present to you role of ultrasound in the management of breast cysts. Next, please. Ultrasound as a modality is very important in breast and in other organs in general. It has many characteristics. It uses non-ionizing radiation, so it's safe. And it is available in all centers, even the peripheral and rural areas. And it is affordable. It is less expensive than other modalities. It is straightforward to perform. And now there are portable machines by which you can go to different departments, ICU or parts in the hospital. Next, please. Yeah, the real-time nature of ultrasound is useful for evaluation of physiology as well. For example, in fetal, heart, and so on. Also, the characteristic of Doppler evaluation of organs and vessels, it adds a dimension of physiologic data not available in other modalities. And it might not be affected by metallic objects as what is seen with CT and MRI. An ultrasound examination can easily be extended to cover other organ system and evaluate the contralateral extremity. As Dr. Abdullah Jabir always tells us, you should communicate with the patient, take history from him. If you need more information from any other organ, you are free to move on. There are few, if any, contraindications to the use of ultrasound compared with MRI or contrast-enhanced CT. Next, please. Coming to breast ultrasound in particular, it is best performed with a high-frequency linear array electronically focused transducer with an accompanying computer enhanced imaging. The typical operating frequency, which give best imaging, are in the range of 7.5 to 15 megahertz, and these allow the delineation of subtle lesion characteristics to assist in the discrimination between benign and malignant lesions. Now we can also connect them to our phones, making it more easy. Next, please. In the future, and as Dr. Hiba presented to us an amazing lecture in the beginning, talking about the automated ultrasound. Also, the role of ultrasound will continue to grow, particularly with the advent of 3D ultrasound and in evolving area of breast lesion ablation techniques using modalities such as radiofrequency ablation or laser therapy. Ultrasound is a very important tool in the assessment and management of breast disease. It has dramatically changed the way breast cancer is managed. Breast ultrasound has its greatest role in the diagnostic workup of symptomatic patients. As we will see later, it will contribute in aspiration of cysts, thus relieving pain. Let us take a quick overview of the normal breast tissue. As we see the pectoral muscle on the back, and then the glandular tissue, fat, skin, nipple. We'll see how it appears in ultrasound. Next slide, please. Yeah, the transducer, as we said, shows superficial organs. Yani it's the linear transducer allow us to see the superficial organs. We'll see the skin, the glandular tissue, fat, pectoral muscle, ribs, and even to the level of the lung. Next, please. Here is how the tissue appears in mammography and in ultrasound. There, we are now concerned with the ultrasound. The glandular tissue is in the middle. The fat appears gray, and then the fat globules and the ducts. Next, please. Yes, this is a more clear demonstration of the skin, the most superficial, and then the fat, followed by the glandular tissue, pectoral muscle, ribs, intercostal muscles, and lungs. Next, please. Now we come to the topic, which is breast cysts. Breast cysts are a common mammographic and sonographic finding, and they can be of different types. We have simple breast cyst, complicated breast cyst, and complex breast cyst, which are more, they are now termed solid and cystic masses. Simple breast cysts typically are well-defined, anechoic lesions with imperceptible wall. And they show posterior acoustic enhancement, as we will see in the coming slides. The complicated breast cyst contains intracystic echoes and debris with other features of a simple cyst. The complex breast cyst, or it is now termed solid and cystic mass, has thick wall with thick septa or intracystic solid mass. Next, please. Yeah, talking more deeply about the simple breast cyst, they are common benign cause of breast lump in women. They come presenting with a lump. It may be painful or non-painful. The clinical presentation, it may be asymptomatic or present with a breast lump. Some patients may have associated pain or tenderness. Or it might be impalpable at all, يعني an incidental finding. Pathology, they are fluid-filled sacs inside the breast and are always benign. Regarding the simple, are always benign. They are PIRADS 2. It's extremely important to determine the cystic nature of a palpable lump, because then you can really reassure the patient that everything is fine. They can be classified according to size into microcysts, less than 3 millimeters, macrocysts, more than 3 millimeters, and microcysts are found commonly in fibrocystic changes. Next, please. On ultrasound, the typical features of a simple cyst are echolucent or black pattern, round or oval shape. It is sharp, circumscribed margin, posterior enhancement. It may also show reverberation artifact, imperceptible wall, and peripheral calcification may or may not be there. As we see, this is the posterior enhancement. Because it's very clear, it shows the tissues beyond it clearly. Unlike in tumors in which we see shadowing. Next. Yes, this is an example of a cyst, oval anechoic cystic lesion measuring 25 by 25. There is no solid component, no septations. Yes, ultrasound is superior in the area of characterizing cysts. And if you see a cyst in CT, you can further characterize it by ultrasound, because ultrasound has the ability to show even very fine septations. That is why ultrasound is superior to other modalities in this way. It shows you the septations, the internal contents of the cyst. Next, please. Yes, this is how the enhancement appears. The tissue beyond it will become very clear. Next. And we make use of this generally we make use of this characteristic, for example, in abdominal ultrasound. You ask the patient to drink water so that through the stomach you can see the pancreas and other tissues. So this shows how the cyst contents are so clear that they show the tissues beyond. Here is a typical example of multiple cysts in a woman who felt a lump in her breast. Although they are many, but only the one in the middle was symptomatic. The other cysts were not palpable because they just felt like surrounding normal breast tissue. It is very common to find more cysts in a woman who presents with a palpable cyst. And they are usually multiple. Yes, this image shows a woman who had multiple small cysts in both breasts, and all of these were not palpable. Next, this is a simple cyst. As you can see, there is no perceptible wall, and it is having all the characteristics of a simple cyst. Next, treatment and prognosis. Simple cysts are benign by RADS 2. When typical features as the one before are seen, no further workup is required. But for symptomatic large cysts, they may warrant aspiration. In this situation, cytological analysis is usually not required if it is simple, unless it contains bloody material. Simple cyst aspiration showing straw-colored fluid can be discarded, and it will just relieve the pain and the tension from the patient. Here is the aspirated entire content of the lesion was straw-colored fluid. Next, please. Post-aspiration ultrasound should confirm the cyst has disappeared completely with no residual mass and will confirm hemostasis. Next, please. Now we come to the second type. Oh, okay. Talking about complications from aspiration. They are virtually unknown complications, but they may include bleeding and theoretically infection. Aspiration of cysts can be safely performed without cessation of aspirin, and it causes no problem with coagulation, and so they should not increase in size in postmenopausal women. Next, please. We come to the next type of cysts, which is complicated breast cysts. They are one of the cystic breast lesions that show intracystic debris, which may imitate a solid mass appearance. They should be carefully differentiated from complex cysts, which may require alternative management. Complex, as we said, is now called complex cystic solid mass. Next, radiographic features ultrasound. Usually, complicated cysts have thin wall with or without posterior acoustic enhancement. It can show acoustic enhancement or not according to the content. Homogeneous hyperechoic content, low-level internal echoes, which may change the shape with the patient position. So you can tilt the patient to make sure whether it is moving or not, sloping fluid levels. This is an appearance of a complicated cyst with a thick wall and internal levels. And next, please. This is a case from clinical practice. There are multiple small cysts with thick wall and thick septations. Next. In this, it also appears as multiple with thin internal septations and peripheral calcification. Next, please. Yeah, the challenge is to differentiate a complicated cyst from a complex cystic mass, because these low internal echoes of a complicated cyst may appear as a homogeneous hyperechoic mass. Next slide, please. If there is hemorrhage or inflammatory debris, which is adherent to the wall, applying power Doppler and detection of internal vascularity can positively prove it to be solid mass. In this way, the Doppler will help us in characterizing whether it is a solid suspicious mass or not. On the other hand, Doppler cannot exclude it. We sometimes should depend on biopsy. Treatment and prognosis. complicated breast cysts have less than 2% risk of malignancy and are recommended to be reported as probably benign BI-RAS 3 lesions. Thus, the management is limited to either we do short interval follow-up. If the size changes over 6 months by more than 20%, diagnostic biopsy is indicated. Next option is aspiration, indicated in asymptomatic patient to relieve the symptoms, newly detected cysts, and enlarged cysts. In all cases, if aspiration reveals serosanguinous fluid, then cytological analysis should be performed. Next, please. This is a photo of a complicated cyst. Most cysts have the typical appearance as shown above. They can also show enhancement, like in this case. Next, please. Yeah, this is another infected cyst, which was aspirated. We can see the tip of the needle, and it also shows posterior enhancement. Aspiration is a quick and simple procedure. In most cases, the fluid has a transparent yellow color, as we saw before, but it can be green or brown. Examination of the aspirated fluid is not always necessary. If it is straw color, it can be discarded, but if bloody or brownish, then it has to be examined. Next, please. We come complex breast cyst, solid and cystic mass. This is the third type of cysts. They were previously known as complex breast cysts. It's a morphological type of breast cyst along with simple breast cyst and complicated cyst. They are defined as cysts with thick walls, thick septa, intracystic masses, or other discrete solid components. They are considered BI-RADS 4 and can even be sometimes upgraded to BI-RADS 5, and they need biopsy. Next, please. This is an image for a solid cystic mass. It shows, although we can see this enhancement because of the cystic component, but it has a solid component showing Doppler, showing vascularity. The other one also shows enhancement, but it has a solid component inside. It should not be confused with complicated cyst. Epidemiology breast cysts are...
Can you go back for this cyst?
Yes.
Just sorry for interruption, but very important.
No, you're welcome, most welcome.
Just the Doppler here at the wall represents the vascularity, but the central Doppler with the cystic component represents the flow of the fluid from one compartment to the other compartment. The large mural nodule extend and make like a septum, separating the cyst into two compartments with a small window. And the fluid, the movement of fluid from the smaller to the large compartment result in this Doppler flow. The blue one is not a true color, is not a true vascularity of the cyst. The blue is the movement of the fluid, while the true vascularity at the thick wall peripherally. This is a liaising vascularity. Different colors, blue, white, and red at the periphery represent the vascularity. While the central one is not, we should not call it as increased vascularity because it is within the fluid itself. Thank you.
Yeah, thank you so much. This takes us to the information that ultrasound is an operator dependent to the ultrasound. So you have to manifestation of all the artifacts which appear and how you should adjust the machine to give you perfect results. Okay, next slide, please. Epidemiology breast cysts are extremely common and are present in most women over 40 years old. Breast ultrasound allows its detection, and the correct diagnosis of cyst has been reported to be almost 100%. 5% of breast ultrasound examination report complex cyst. Complex breast cyst or complex breast mass, cystic solid masses, the malignancy rate of 0.3%. Among breast neoplasms, it still has a substantial probability of being malignant, 23 and 31% in two series. Next, please. Pathology. They are associated with a variety of benign. As we said, they can be benign lesions, atypical and malignant pathological diagnoses, including fibrocystic changes, intraductal papilloma, abscess, hematoma, fat necrosis, fibrocystic mastopathy, phylloids, tumor, papilloma, atypical ductal hyperplasia, ductal carcinoma in situ, and infiltrating ductal carcinoma. So it could be a spectrum of diagnoses. Okay, the radiographic features on ultrasound, the presence of a thick wall or septum or intracystic mass is characteristic of complex cysts. The majority show posterior acoustic enhancement due to the cystic component. The margin may be macro or microlobulated, indistinct, or even irregular. As we said, it can be upgraded to BIRADS 5. Next, please. Depending on their sonographic appearance, they have been categorized into 4 categories using criteria adapted from Berg et al. Type 1 masses with a thick wall, more than 0.5 millimeter, or thick septa, more than 0.5 millimeter, and they have predicted value for malignancy 7%. Type 2, masses of intracystic type with 1 or more discrete solid mural lesions with a cyst PPV for malignancy is 16.7. Type 3, masses containing mixed cystic and solid components with the cystic portion occupying at least 50% of the mass, PPV for malignancy 61.1%.
Okay, wait. Go. Yeah, you come for the BIRADS now. You correlated with BIRADS 4A, 4B, and 4C. So the first one is 4A. If we have just a thick septa or thick wall only, it would be BIRAD 4A. Type 2, it would be with a solid mural nodule. Okay, it would be BIRAD 4B, unless there are other features. This is if it is an just isolated cyst with thick wall or thick septum, it would be just, we have to report it as BIRAD 4A. If it is cyst and with mural nodule, without vascularity, without anything, we can report it as BIRAD 4B. And if it is more than that, mixed solid cystic and solid components, it would be BIRAD 4C. But if there are other features, we will upgrade it. We should not stop at this level. Okay, thank you. Continue.
Type 4, next slide, is masses that were predominantly at least 50% solid with eccentric or central cystic foci. PPV for malignancy is 44.8. Treatment and prognosis, some authors find that the complex cystic lesions have 23% up to 31% risk of malignancy, while others estimate the risk as 0.3%. The former consider the complex breast cyst as intermediate BIRADS 4B, while the latter consider them to be BIRADS 4A. Okay, next, please. The decision as to whether any interventional technique should be used is guided by clear indication and can be compatible with the patient's history and result of mammography. The radiologist should choose the appropriate measure from the following alternatives: either close monitoring or sampling, fine needle aspiration. Next, please. For fine needle aspiration, it is the first interventional it is the first interventional procedure that should be performed when it is difficult to differentiate between a complicated cyst and a predominantly cystic complex mass. If you find purulent fluid, this suggests inflammatory lesion and should be assessed by microbiological analysis, while hemorrhagic fluid raises the possibility of malignancy and should be analyzed cytologically. Assessing the lesion after aspiration is important to depict the solid component. If a solid component remains, core biopsy should be performed in the same session. Okay, next. Biopsy. Core biopsy should be the first intervention if there is a proven solid component associated with suspicious finding in the mammogram. example microcalcification or architectural distortion. Next. Practical points. Moving the patient to a decupitous position is useful to differentiate the solid masses from thick debris. If the echogenic component is mobile, it represents debris, pus or a clot. If the echogenic component is immobile, it may represent either a true intracystic mass or a debris adherent to the wall. In all cases, if aspiration reveals serosanguinous fluid, then cytological analysis should be performed. Thank you so much.
Thank you very much, Amal. That was very nice and informative presentation. Well to the point. Any questions for Amal?
Thank you, Amal. Thank you, Amal. Really amazing and to the point. Thank you very much.
Thank you so much for your attendance.
Okay, is Dr. Rahab ready or can present? I think it's not with the audience, so shall we shift to the break, Dr. Rabat?
We have break.
Yes.
Okay, no problem. Regarding Dr. Medina is here. She has one of her cases demonstrate a normal variant. I have seen it on female, but this is the first time to see it in a male breast, one of her mammography. And she showed also on MRI, confirmed the findings. Very interesting. I forget, at that moment, I was concentrating on the challenge of gynecomastia. I forget to ask her to put that image. Are you there, Dr. Medina, or left? To show us that image. I will ask her to show it to us at the end. No problem. We can go for the break and come back. During the break, we can manage with Dr. Rahab.
Okay, inshallah.
Okay.
So now we have a break for 30 minutes. Please join us again in a 30 minutes. Thank you for watching. And we wrap
Tell
up.
them the exact time. At 3 o'clock?
Yes. 3
Or
o'clock,
before
inshallah.
3 o'clock? 3 o'clock? Okay. Join at 3 o'clock. Thank you. Thank you.
You can share it in the screen, Hiba.
Okay.
Change the
عدل
timing.
عليها.
Right. Thank you.